we'll be discussing some high yield topics related to INI-CET and some important images, as well as we'll try to solve some previous year questions that have appeared in the recent years. So this is a split up. As you can see, we get generally 4 to 5 questions every year from anesthesia. So out of 200, around 2% come from anesthesia. Though this is a small number, let me tell you, if you can thoroughly read anesthesia, it's a very high scoring subject and you can score even 100% and you can crack all the questions. So when you see the last 5 years topics, majority of the questions have come from critical care and pain and palliative care. So pain medicine and palliative care, of late from last 2 years, many questions have come from this topic. And there are some topics like pharmacology, then pre-op anesthesia assessment, airway management and monitoring. These are the evergreen topics. So in this session, we'll try to focus on these evergreen topics as well as the topics that have become important in recent years. So if you see, after Corona, the questions from airway management and oxygen therapy have gained lot of attention, and every year we can expect one question from this topic. So let us not waste any time. Let us begin with the first topic for today, that is history and introduction. Good evening, Dr. Naren. So from the history chapter, all these years we were reading only historical milestones until this thing came in the recent exam. So what is this? This is a story, and let me tell you, in the early 18th century, the China used to sell or export tea, silk and porcelain vessels to Great Britain through the traditional silk route. Okay, this is the sea route. Also, apparently there was a land route, and the Chinese heavily benefited from this trade. They used to get tons of silver in exchange for these goods. So this was a heavily imbalanced trade, and it was in the favor of Britain. Sorry, it was in the favor of Chinese. So to tackle that, the British wanted to do something really evil. They started growing opium in different parts of India. They stored it in different warehouses across India, and through the East India Company, they shipped it to China, where the Chinese population became dependent. Everywhere opium dens were seen, and it was having a lot of crippling effect on the Chinese economy as well. So the Chinese emperor ordered to destroy all the opium that was stored in China. So this led to the opium wars in 1838 and later again in the 1870s. So the first and the second opium wars are a black dot in the Chinese history, and both the wars were lost by China and the British. And in the second opium war, the British and the French gained a lot of momentum, and they gained a lot of power, and they dominated the Chinese. So why am I telling this? Because this question came recently. So let's try to answer this question. Good evening, Dr. Raj. So before we solve this question, let us see how should we approach an MCQ. So we should begin by carefully reading the MCQ stem, go through all the options carefully, and the MCQs are often designed in such a way that they'll confuse you. Okay, so For example, if it's a leg spinner, he'll bowl the wrong one. Like this is the Shane Warne bowling the googly. Okay. In similar fashion, the examiner would like to bowl you so many googlies and he'll try to confuse you. And your aim should be to look for keywords and clues in the question, and you should eliminate the wrong options from the question. So that makes it easier. Try to narrow down to the best possible answer, and with the knowledge and experience you have, try to select the most appropriate answer. Knowledge is the key here, but some questions can be answered without knowledge as well. Common sense is important. Okay. Finally, avoid overthinking. Mark the option which you believe is right and trust your instincts. And before you go to the next question, make sure you have marked the right answer. So let's go back to the question. The question here is, in late 18th century, British East India Company was smuggling which of the following into China? So we saw this, and can anyone answer? Hello, Dr. Nishant. Hello, Dr. Daivik. You can type in the chat box. Okay. So the options given are magic mushrooms, opium, pepper, and tea. We saw that the British were pushing opium into China. So the right answer here is opium. Let us quickly see some important historical milestones that are relevant to anesthesia. It was Joseph Priestley who first invented oxygen and nitrous oxide, and Humphrey Davy described the analgesic properties of nitrous oxide. He said that it can be used for painless anesthesia. Hello, Dr. Sonali. It was Crawford and William Clark, the two dentists, who used ether for the first time in 1842 for a dental procedure. The most important among these is by Horace Wells, who gave the first demonstration of nitrous oxide as an inhalational agent. It failed so badly that eventually he committed suicide. His assistant, W.T.G. Morton, in 1846, went on to demonstrate ether as an anesthetic for general anesthesia for a removal of a neck tumor at Massachusetts General Hospital. The operation theater till date is known as the Ether Dome, and he is considered the father of anesthesia. So remember, who's considered the father of modern anesthesia? It is W.T.G. Morton or William Thomas Green Morton. In the same year, Oliver Wendell Holmes coined the term anesthesia for procedures that help deliver painless surgeries. Okay, so remember, this year it is very important. It is on 16th of October that W.T.G. Morton did this demo in the year 1846, and till date this 16th of October is celebrated as World Anesthesia Day. So though ether was the first general anesthetic, later on in the 1840s, late 1840s and early 1850s, chloroform was very popular. It was advocated by an obstetrician called James Young Simpson that it can be used for painless deliveries, but it was actually Dr. John Snow who used it on Queen Victoria during childbirth, and he made it popular across Europe. So both ether and chloroform had to be given using a mask. So that mask was actually launched in 1890 by a person called Schimmelbusch. He designed the Schimmelbusch mask. So it was mainly designed for using ether. Later on, they started using it for chloroform as well. So simultaneously, in the 1884 year, an ophthalmic resident called Kohler, who was using cocaine, tried to demonstrate its use as a local anesthetic for ocular procedures. So first local block was given by Kohler in the year 1884, and it was Sir August Baer who delivered the first spinal block using the same cocaine in the year 1898. 10 years later, he went on to describe the Bayer block, also called as the IVRA, intravenous regional anesthesia. Okay. So it was Henry Boyle who designed the first anesthesia machine in the year 1917. Till date, it's called the Boyle's anesthesia machine, and we still use it in some of our OTs. It was Dr. John Lundy and Rolf M. Waters who gave the concept of balanced anesthesia. What is balanced anesthesia? Balanced anesthesia was once asked in one of the old NEET papers. Remember, it is optimal use of minimal dosages of pre-medications, inhalational agents or induction agents, and analgesics to provide the best possible anesthesia with minimal side effects. So John Lundy also conducted some clinical trials on thiopentone sodium, and later on in 1934, thiopental sodium was marketed in the US. Sir Ewan McGill first described endotracheal intubation, and he also helped form the Association of Anesthetists in the year 1932. Until now, a lot of people had tried to describe the stages of anesthesia, but it was only in the year 1937 that Gödel described the stages of anesthesia properly, and till today it is considered gold standard. In the year 1892, Sir R.K. Brain designed the first classical laryngeal mask airway. So remember, these are some of the milestones. These may appear in your NEET exams as a fact-based one-liners. In INI-CET, we usually get two-layered questions. We may not get such one-liners, but still good to know this. So if you have a patient, for example, here is a 48-year-old male patient with intestinal obstruction. He is posted for an emergency surgery, that is emergency laparotomy. How do you proceed? So when I get a patient like this, what I'll do? Okay. So when I have a patient, the surgeon will see and he'll post him for a surgery. In this case, an emergency surgery. So what I'm supposed to do is, I'm supposed to examine the patient. So I'll do something called the PAE, that is pre-anesthetic evaluation, where I'll evaluate the patient and simultaneously I'll optimize the patient. After that, patient is taken into surgery. He first undergoes anesthesia. So we should have an anesthetic plan. Once the patient is anesthetized, surgeon can operate, and once the surgery is completed, patient receives post-op care and he is discharged with a advice on discharge, and he is asked to come back. We all know this flow chart, but the part I want to emphasize here is this part. Okay, this is the most important part, and as you can see, the anesthetist is there all the time throughout this period. So we call the anesthetist as the perioperative physician. So that brings us to the next topic, that is preoperative assessment and optimization. So in this topic, try to focus on these concepts, that is history taking, risk stratification, Mallampati classification, optimization of medications, and fasting guidelines. So these are some of the most important concepts, and you cannot go to exam without knowing these topics. So in history taking, you'll be asking patient for his current medical history and current medications. Patient can have hypertension, diabetes, any respiratory illness, thyroid illness, psychiatric illness, seizure disorder, or any other long-standing illness. Also, it is important to ask for allergic history, as we'll see a lot of cases with latex allergy, especially patients will have allergy to the indwelling catheters. This is commonly seen, so you should not miss the allergy part. Also, we have seen patients developing allergies to antibiotics or analgesics. Please try to elicit allergic history. We also ask for history of use of alcohol, tobacco chewing, as well as smoking. It is very important because using alcohol and tobacco interferes with metabolism of the anesthetic agents. Also, quitting smoking helps a lot. Even overnight quitting of 12 to 24 hours is considered very useful because it brings down the carbon monoxide levels to a great extent. Ideally, patient should stop quitting for around 6 weeks prior to surgery. So once we ask the allergic history, we try to ask the patient about his exercise capacity or the effort tolerance. What is effort tolerance? We'll ask the patient what routine activities he is able to carry out. So based on that, we'll know whether the patient can undergo surgery, whether he can tolerate the anesthesia, whether he can tolerate the surgical stress. Okay. Also, we can predict the occurrence of post-operative pulmonary complications by eliciting this history. We should also ask for past history, where if the patient had undergone any surgery, especially under general anesthesia, where he had seen delayed recovery, or if any patient with repeated failed spinal history, okay, and patient with predisposition to malignant hyperthermia. These are all very important aspects of history taking. And also look for history of recent illness like respiratory illness or even COVID-19. I have put COVID-19 here because we just finished the pandemic, and in the last year there was a question on this. So we'll go to that question later. But first we'll see when can we do the elective surgery after COVID-19. So timing of the surgery after COVID-19 illness. So if your patient was asymptomatic and if he had recovered from mild illness without any respiratory symptoms, you can go ahead with surgery within a month, that is 4 weeks. But if the patient was symptomatic but did not require hospitalization, postpone the surgery for 6 weeks. Patients who had coexisting illness, that is diabetes, or patients who were hospitalized, or if it's a immunocompromised patient who was symptomatic, try to do the elective surgery after a period of at least 8 to 10 weeks. So if the patient gives history that he was admitted to ICU due to COVID-19, try to avoid surgery for 12 weeks. So the timing of surgery is very important because COVID-19, as you know, was associated with very high mortality, and this used to be 5-fold in patients who were posted for surgery. So the question is here. Try to answer this one in the chat box. How long should the elective surgery be deferred for a patient after recovery from asymptomatic illness? So this was the first thing in the list. So do you remember? Okay, the answer here is 4 weeks. So I was talking about the exercise capacity that time, or the effort tolerance. So exercise capacity or the effort tolerance is measured using something called as metabolic equivalence of task. So remember, a healthy patient will have a MET of 10. Okay, he can swim quickly, he can run, or he can jog briskly. Okay, depending on your patient's age, you should try to elicit the history. So if you have a old lady who's doing her work at home, who's able to do routine gardening work, that means she's got a MET of 4. In a person aged above 60 to 65 years, the person with a metabolic equivalent of task of 4 is considered good effort tolerance. Okay, so ideal is 10. Okay, but we'll never get 10 on 10. Okay, so if you get more than 4, that's enough. Okay, but anything below 4 means there is something serious ongoing. We have to optimize the patient before taking him for a major surgery under general anesthesia. So how do you classify this risk? How do you know which patient is at a higher risk, which patient is at a lower risk, and how do you communicate it to someone else? Suppose you examine a patient, but the patient doesn't want surgery here, he's going to your friend's hospital. So how do you communicate it? For that, we have a standard way of risk stratification called the American Society of Anesthesiologists, that is ASA physical status classification. Okay, so what they do is basically the patients are divided into 6 categories depending on their health. Okay, so if your patient is having normal health, that means he is ASA 1. So he is a non-smoker, doesn't drink, or minimal alcohol use. Okay, but if the patient is a known smoker or a social drinker, or if the patient is pregnant, or if your patient is otherwise healthy but aged above 60 years, or if that person has a controlled hypertension, diabetes, or asthma or COPD, he falls under category 2 because he has got a mild systemic disease or mildly deranged system. Okay, the person with severe systemic disease, that is person who has been abusing alcohol left, right, center, or who's dependent on alcohol, or person with morbid obesity or uncontrolled hypertension or uncontrolled sugars or uncontrolled asthma or COPD, or a person with past myocardial infarction or PCA or pacemaker, or someone with old stroke, or someone with end-stage renal disease who's getting regular hemodialysis, they all fall under this category, severe systemic disease. Okay, but if it goes to next level, that is if it is posing a constant threat to life, then the threat or the category increases to ASA 4. Okay, so more sick the patient, the ASA class goes higher and higher. Okay, so if the person is having ongoing myocardial infarction or very recent myocardial infarction, recent here is a relative term. MI for up to 6 weeks also is recent. MI for up to 6 months also is recent. But thing is, if it has caused severe threat to patient's life, it's classified as ASA 4. Okay, ongoing CVA, ongoing transient ischemic attack, acute renal failure, sepsis, ARDS, all these fall under category 4. Okay, so generally patients with ASA 4 require ICU care. Okay, yes. So if you have a person in emergency department, say, who's not expected to survive for more than 24 hours without any surgery, then he's classified as ASA 5. Okay, yeah. So for example, the person presenting with intracranial bleed with mass effect, or a polytrauma victim, or somebody with ruptured abdominal aortic aneurysm, or someone with ongoing MODS following sepsis. Okay, all these fall as category 4. Here, surgery is very important. Simultaneously, giving good ICU care is equally important, and higher risk of death. And if somebody is already dead, that is, if he is declared brain dead, he falls under category ASA 6. So why do we need to know this? Because we'll be harvesting organs for donation from such patients. So those people also need to undergo PAE. So such people we classify as ASA 6. And for emergency surgery, as it was in the last case scenario we saw, we suffix E. Okay. Yes. Good evening, Dr. Shimona. So let us try to remember this with the help of picture. So we have a person with a nice healthy body here. He's an athlete. He's obviously ASA 1. We have somebody who's a chronic smoker. He's ASA 2. We have an old lady who's on a wheelchair because of stroke she suffered few years ago. She's ASA 3. And person who's having ongoing chest pain or MI, we classify him as ASA 4. Person who had severe head injury and is almost comatose, we classify as ASA 5, and the brain dead patient is ASA 6. So try to remember this picture, okay, and try to answer this. So please post in the chat box which of the following best defines a patient with ASA class 3 of physical status. Okay, mild illness, moderate illness, severe systemic illness, or severe systemic illness that is a constant threat to life. Can I have an answer, please? Okay. So we'll try to solve this. Okay, though this is a easy question. So what is mild systemic disease? Okay, what is moderate? Okay, fine. You all know that these two are wrong. Okay, and I told you if it is severe systemic disease with constant threat to life, what is it? It is ASA 4. Yes. So the answer here is severe systemic disease. Okay. So coming on to the next step in anesthetic evaluation, that is airway evaluation. This is a very important concept. So in emergency situation, we use something called as the lemon approach. Okay. So what we do here, we look for predictors of difficult airway. We look for predictors of difficult mask ventilation. We evaluate the patient by 332 test. We do the Mallampati classification. We look for other risk factors like obesity and obstruction in the airway. Also, we examine the neck. So let us see in detail. So what are the conditions that you have to look for which can tell you mask ventilation is going to be difficult? Okay. What is mask ventilation, by the way? Okay, mask ventilation is ventilating a patient with the help of a face mask. Okay, so mnemonic for this is bones. Okay, what is this bones? Okay, I'll tell you what is this bones. First B is this person's beard. Okay, so remember this person, so we'll remember everything. So the first thing is beard. And what is next? Next is O. What is O? O for old man and obese lady. So the Santa Claus is aged above 60. He doesn't have teeth. Okay, so that is the funda here. Old age and obesity. This lady here has a mild to moderate degree of obesity. So it is going to be difficult to hold mask in her. You will need to use both your hands. So again, this falls under the category difficult mask ventilation predictor. Okay, then what else? Then any trauma to the nose or anywhere on the face. Okay, that is the N here. Trauma to the nose. Okay, yes. And E stands for edentullousness. I've already told that. And any and any teeth anomaly. That is, one is edentullousness, that is in old age they don't have teeth, and any teeth anomaly like buck teeth, loose teeth, etc. Okay. And the S here is snoring. Okay. So remember this person, old man who has no teeth and he's got a large beard. Okay. And he snores a lot and he's fat. Okay. Try to remember this thing, and these are the predictors of difficult mask ventilation. And next step is to evaluate a person by 332 test. So you ask the patient to sit in front of you, or you go stand next to the patient and ask him to insert 3 fingers, his own 3 fingers, into the mouth. So if the mouth opening is more than 3 fingers, that means it is adequate for laryngoscopy. The thyromental distance and the thyrohyoid distance, if it is 3 fingers and 2 fingers consecutively, that means the person is having a normal airway. Any variation in this indicates anteriorly placed airway or the anteriorly placed larynx. The next step is to ask your patient to open the mouth widely and you look at the oropharyngeal structures. You should be able to see the uvula. You should be able to see the palate and the pharyngeal pouches, pharyngeal fosses. Okay. So what all you will see? Tip of uvula, the palate, soft palate and hard palate, and the pharyngeal fosses. So if you are able to see the pharyngeal fosses, the tip of the uvula, the soft palate and the hard palate, it is classified as Malampati 1. But if the tip is obscured and you cannot see the pharyngeal fosses, then it is Malampati 2. That is, you are seeing part of uvula, soft palate and hard palate. This is MP2. Remember, a normal person usually has MP1 or MP2. But if the tongue is large and if it is obscuring the airway, then the person may have these 2 views. Okay. Here you are able to see just the part of soft palate and hard palate. In this case, you are seeing only the hard palate. So this soft palate and the hard palate. Here only hard palate is seen. So this is MP3 and this is MP4. So in this case, it is considered difficult airway. So remember, Malampati 3 and 4 are difficult airways. What else you'll check? As I said earlier, you are going to look for obesity and you're going to look for any obstruction in the neck. Okay. Any obstruction in the airway, sorry. And you're going to measure some measurements in the neck. First thing is thyromental distance. Okay. If it is thyromental distance, if you can see here, is measured from chin to the thyroid cartilage. Okay. So this distance is usually 6.5 centimeters, and anything below this indicates a difficult airway. Similarly, obese people have short and thick neck. So circumference of neck is important. Anything above 17 centimeters or 17.5 centimeters is considered an indicator of difficult airway. Also, you should check for flexion and extension at the neck. If it is restricted, that means you have to do some additional tests as well. You can try to elicit this sign. What is this? Prayer sign. So when you do namaste, when you do this, you should be able to see some light passing through. So this is normal. Okay. But in patients with rheumatoid arthritis, connective tissue disorders, or uncontrolled diabetes, you won't see light. Okay. So this is called positive prayer sign. It indicates that the movements at atlanto-occipital joint can also be restricted in such patient. So you should be extra careful. Look for any neck contracture and neck swelling before you send the patient back and document it. So let's recall what are the predictors of difficult airway. They are, remember the predictors, bones, that are the predictors of difficult mask ventilation. If the patient fails 332 test, or if the patient has a Malampatti grade of 3 or 4, or if he has obesity, obstruction, or poor neck mobility, then you classify him as a person with difficult airway. So why it's important? You need to make arrangements pre-operatively if any of these things are present in the patient. So the examination is incomplete unless you have examined the spine. So you got to look for the spine. There is a normal spine, straight and upright. Here, when you see from behind, the spine appears to have a kink to the right. So this is scoliosis. And when you see from the side, this is how a person should look. But a person with lordosis will have this deformity, whereas a person with kyphosis will have a forward stoop. Okay, so all these are important in positioning of the patient, and also these are important if the patient is planned for any spinal or epidural anesthesia. So how do you optimize the patient? You got to give some advices. So your patient will have a lot of comorbidities, and you have to advise that patient which medication to stop, which medication to change. Okay, so remember this mnemonic, Saturdays. Okay, Saturdays stands for S, that is statins. Statins have to be continued. Steroids, if he has taken it for more than a week in this year, you should continue it. Patients who are taking antihypertensives should continue them, except ACE inhibitors and ARBs, which need to be stopped. Any anti-anginal, anticonvulsant, antithyroid medication, ATT, antipsychotic should be continued, and if he is taking MAO inhibitors, must be stopped before surgery. If a patient is taking aspirin, see what dosage he is on. If he is taking 75 mg aspirin, he can continue that. Otherwise, if it is 150, he has to stop it. So statins and drugs starting with A, and next T for thyroxine. All the thyroid supplements should be continued on the day of surgery. And what to stop? Remember, on the day of surgery, insulin should be withheld, oral hypoglycemic agents should be withheld. And 4 to 6 hours before surgery, any unfractionated heparin, if he is on, last dose should be given at least 6 hours before the surgery. Similarly, if the patient was advised low molecular weight heparin, should be stopped 24 hours before surgery. Lithium should be stopped 3 days before surgery. Aspirin and dabigatran, which are antiplatelets, should be stopped. Aspirin, as I said, 150 mg, and dabigatran, which is a newer antiplatelet, should be stopped 5 days before surgery. Warfarin and clopidogrel should be stopped 7 days before surgery. So try to remember this picture. That is how we are going to remember this. Okay. All the MAO inhibitors should be stopped 2 weeks prior to surgery, and all the herbal medications, oral contraceptive pills must be stopped 6 weeks prior to the surgery. So what do you advise your patient? You advise your patient to fast overnight generally. Okay. So the latest guidelines for nil per oral are: patient can continue to take clear liquids 2 hours before the surgery, and if it's an infant, breast milk can be given up to 4 hours before surgery. Anything else other than that, like non-human milk or infant formula, should be given 6 hours before surgery. So the child should not have received any of these things until 6 hours. Okay. The last thing you can give is 6 hours before surgery. Light meal for an adult can be given up to 6 hours before surgery. And anything heavier like fried fatty food or meat or biryani should be given 8 hours before surgery. That is the last. You can't have beyond that period. Okay. Minimum 8 hours of fasting is necessary. Okay. Yes. So you have to explain your patient what is your anesthetic plan, and as you know, any procedure will have its own requirement. So depending on that, we can give local anesthesia. Local anesthesia is usually given for a minor procedure like suturing or small lump removal, okay, or lipoma removal, etc. So here we inject the field with a local anesthetic agent. Monitored anesthesia care, this we usually see in the ophthalmic OTs, where we are called in as a standby support. Anesthetist will be monitoring the patient, whereas procedure is carried out under light analgesia under guidance of anesthetist. We have something called as general anesthesia, where we knock out the patient. Patient goes into sleep and we wake him up, to put it simple. Okay. And we have something called regional anesthesia, where we give nerve blocks blocking a particular nerve or a plexus, or we also have the spinal anesthesia and the epidural anesthesia. These are useful for surgeries below the level of umbilicus. Okay. Good evening, Dr. Meenakshi. So what are the steps of general anesthesia? The first step we saw, that is pre-op assessment. Then we take the patient to OT after explaining him that he's getting general anesthesia. So patient will be receiving pre-medication, induction agent, maintenance agent, and reversal agent. Okay. So pre-medications are some drugs which we give to optimize the patient before surgery. Induction is usually by the induction agent, that is either intravenous or inhalational agent. And maintenance is by same drugs. Okay. We'll require muscle relaxants for producing muscle relaxation, and to reverse the effect of those muscle relaxants, we use reversal agents. Okay. So after reversing the patient, only after recovery, we are going to shift him to the post-operative period. So that brings us to the next topic, that is pharmacology of anesthetics. Okay. So first we'll see what are pre-medications. Then we'll see some important points from all these agents. We'll see what are commonly used muscle relaxants and reversal agents and local anesthetic agents. So this pharmacology session, students, will be a very rapid one. I'll be telling you only what is important, and we'll try to cover the entire pharmacology in 15 to 20 minutes. Okay. So before we start with pharmacology, let us recall that in 1937, Goodale described the stages of anesthesia, he told that there are 4 stages of anesthesia. Stage 1 is stage of analgesia. So in this plane, most of the minor procedures are done. What are those minor procedures? D&C, suturing, etc. Okay. Whereas all the major procedures, remember, are done in stage 3. Okay. So coming on to pre-medication. So purpose of using pre-medication is to reduce anxiety, post-operative nausea vomiting, to produce sedation, and to reduce the anesthetic risk. So the main goal is anxiolysis and sedation, for which we use benzodiazepines like midazolam, lorazepam, and diazepam. We use opioids mainly for producing analgesia, along with that anxiolysis and sedation. The drugs used are fentanyl, remifentanil, etc. We use phenothiazines for reducing secretions as well as for anxiolysis and producing sedation. In the olden days, most of the surgeries, our seniors used to do it with phenothiazines and benzodiazepines, all the minor procedures I'm talking of. Okay. And to reduce the secretions, we use anticholinergics like glycopyrrolate and atropine. Remember glycopyrrolate, it was asked in your exam. So we use it for reducing secretions. So other drugs that we use are antacids, proton pump inhibitors, H2 blockers, prokinetic drugs, and serotonin antagonists. So why we use this? We use this for gastric emptying and for preventing post-operative nausea and vomiting. So the question that was asked is, what is the role of glycopyrrolate in pre-medication? So the options you can answer, students. It increases the dose of IV agents, decreases secretions, reduces anxiety, and induces sedation. So the right answer here is correct. It reduces the secretions. Coming on to the IV agents. IV agents, as you know, are given intravenously and they enter the circulation and they target the central nervous system, particularly the GABA A receptors, NMDA receptors, or the alpha 2 receptors. All the benzodiazepines and thiopentone, propofol, etomidate will target GABA A receptors. Remember this fact, it can come in your exam. Ketamine targets the NMDA receptors, whereas alpha 2 receptors are targeted by dexmedetomidine. Okay, and the potency of these drugs is dependent on lipid solubility. So that determines the dosage that we are supposed to give for the patient. And all these drugs are primarily metabolized in liver and excreted through the kidneys, except etomidate. Etomidate is metabolized by the liver plasma esterases. So is it safe in liver failure? Absolutely not. Okay, someone asked me this recently. So etomidate we try to avoid in patients with chronic architectural liver disease, okay, or hepatocellular carcinoma in such cases and all. Okay, but remember, it is not metabolized by conjugation or biological oxidation. It is, unlike other agents, it is metabolized by the plasma esterases. Okay, and how do you classify these agents? Intravenous agents are classified as barbiturates and non-barbiturates. So what are the barbiturate compounds? Thiopentone is barbiturate compound. Rest everything is non-barbiturate. Okay. So let's remember some points. The short acting agent that is used as a pre-medication is midazolam, okay, and it is reversed by flumazine, okay. The drug that is used in narcoanalysis and contraindicated in porphyria, acute intermittent porphyria, is thiopentone. The drug that is preferably used for ECT is methotrexate. Methotrexate, if it is there in your options, it is the drug of choice for ECT. If it is not there, if they have given thiopentone, then go for thiopentone. Okay. Yes. And the drug that is used for daycare surgery, short procedures, and TIVA. What is TIVA? Total intravenous anesthesia. The agent of choice here is propofol. And for a pediatric patient or a trauma victim who is in shock, we use ketamine. The most cardiostable drug is etomidate, and the drug that is used for producing conscious sedation. What is conscious sedation? You guys must have seen some videos where patient is listening to music and neurosurgeon is doing brain surgery. So that is called conscious sedation. And what drug we use for this? We use dexmedetomidine. So it produces very good sedation. Therefore, it is used in ICUs for sedation as well. Before this drug came, we used to use morphine. Now we don't use it anymore. We use dexmed, but it can cause severe hypotension. So the sedation produced by dexmed can be reversed using this drug called atipamezole. Okay, this can come in your exam. It's a important fact. Okay, let us now see some important side effects. So the drug that can cause apnea on rapid IV is midazolam. This is only MCQ value. Remember, any sedative, if given rapidly, can cause apnea. But midazolam is known for it. Okay, so if that is there in the options, mark that. So any patient, he complains of pain after accidental intraarterial injection, he would have received thiopentone. Remember, the drug that causes painful intraarterial, the drug that can cause painful arterial spasm following accidental injection into the artery is thiopentone. The drug that is painful on IV injection is propofol. So how do you manage this? Propofol we are using for induction. So if the patient says pain, we can't give propofol. We can. We give lignocaine before giving propofol, and then we give the propofol. Propofol, if given for long periods, like more than 2 days, more than 48 hours, at a dosage of 4 mg per kg per hour, these prolonged infusions will lead to propofol infusion syndrome. This is often seen in ICU patients where we give propofol for sedation. Ketamine is associated with dissociative anesthesia as well as emergence reaction. So when they are coming out of anesthesia, suddenly they'll become restless, they'll have hallucinations, etc. It is contraindicated in patient with ischemic heart disease. It can raise the blood pressure, intraocular pressure, and intracranial pressure. So we avoid this drug in a patient with head injury. The drug that is most cardiostable but causes most incidence of post-operative nausea vomiting is etomidate. It can also cause adrenal suppression. And as I said earlier, dexmed can cause hypotension and also causes hypertension. It is known to cause heart blocks, including atrial fibrillations. So, coming on to the question, what is the role of injections, thiopentone sodium and succinylcholine in ECT? So, this is a slightly old question. So, what is the role of thiopentone here? Okay, it provides anesthesia. Succinylcholine, you will know later, it's a muscle relaxant. Okay, so the right answer is first one. So let's try this one. Try to answer in the chat box, guys. Which of the following agents is preferred for induction in a patient with increased intracranial pressure posted for neurosurgery? Okay, I'm waiting for your answer. Okay, so the answer here is thiopentone sodium. Okay, thiopentone sodium has neuroprotective property, so we prefer this. Okay, coming on to the next set of drugs, that is inhalational agents. Inhalational agents are the anesthetic agents that are inhaled as vapors. They enter the circulation and produce their effect on CNS. They are delivered using a specialized device called vaporizer, and they target both central nervous system and the neuromuscular junctions. They target the NMDA receptors, GABA A receptors. GABA A receptors are nothing but chloride channels, and they also target the potassium ligand gated potassium channels. So their uptake is affected by the cardiac output, cerebral blood flow, blood gas solubility of the agent, anesthetic concentration that we are using, partial pressure of the agent, and degree of alveolar ventilation at minimum alveolar concentration, that is MAC, minimum alveolar concentration. What is MAC? MAC is often a repeated question. So it is the concentration of the agent that produces immobility in 50% of the patients who have received the agent. So it's a number. So remember, lower the MAC value, higher the potency. Okay, we'll first see the MAC values. Methoxyfluorine, MAC value is 0.16. Methoxyfluorine is not in use anymore. Okay, this is just theoretical value. Halothane, MAC value is 0.75. Isoflurane, MAC value is 1.2. Sevoflurane, MAC value is 2. Desflurane, MAC value is 6. And nitrous oxide, MAC value is 104. So, as I said, lower the MAC value, higher the potency. So, which is the most potent here? Okay, you can answer in the chat box. Yes, you are right. Methoxyfluorine has the least MAC value, so it is the most potent. And highest MAC value is of nitrous oxide, and that means it is least potent. So, how do you remember this? You can remember this by remembering Munna Bhai MBBS. So, Munna Bhai MBBS hero is Sanjay Dutt, right? Okay. So, Munna Bhai MBBS. So, M stands for methoxyfluorine. Hero, H stands for halothane. Is, okay, isoflurane. Sanjay, S stands for sevoflurane. Dutt, D stands for desflurane. Okay. Yes. Okay, no, and all that. Nitrous oxide. Fine. So, one more thing you have to remember here. The color of vaporizer used. So, I made hero in red. So, red color vaporizer is used for halothane. Isoflurane is in purple or violet, that is purple. Sanjay is in yellow. So, that is sevoflurane is yellow. Dutt, D, desflurane, that is in blue. So, we use blue colored vaporizer for desflurane. And remember, the vaporizer that we use for desflurane is called, so what is the MAC value? 6. So, it's called the Tech 6 vaporizer. It is a special type of vaporizer. It's a very expensive one that is required for delivering desflurane to the patient. Though desflurane is a very good agent, because of this cost factors, we generally don't get to see this vaporizer in our regular hospitals. So, coming on to the questions, arrange these agents based on their potency. So, who will do this? You can comment in the chat box, please. Okay. So, nitrous oxide, halothane, isoflurane, methoxyfluorine. Which is the most potent here? Remember? Correct. Methoxyfluorine. Then followed by Munna Bhai MBBS hero. Okay. Is Sanjay Dutt, right? or no? Okay. So Munna Bhai hero is. Okay. Right. So the correct answer is 2. So how do you classify these agents? The inhalation agents are classified as GABA A predominant activity and the inhalation agents that are having NMDA receptor predominant activity. So Dr. Meenakshi is asking about sevoflurane. I'll come to that, sir. So remember these 3 gases, cyclopropane, nitrous oxide and xenon. These have the predominantly NMDA receptor activities. Remaining everything work through mediation of the chloride channels, that is GABA A receptor predominant activity. Okay. So among these NMDA receptor activity ones, xenon we know is a inert gas. It's very expensive. It's an ideal gas, so we don't use it. Okay. Even though nitrous oxide is least potent, we used to use it very regularly. Now because of the adverse effects that we have come to light in the recent years, we have reduced the use of nitrous oxide in our OTs. Some of my colleagues have stopped using nitrous oxide. Okay. In remote settings, we still see to that it is used. It's a least potent inhalation agent, but it has got a very good analgesic property. Patient sleeps nicely when they get nitrous oxide. Okay. And also there is cyclopropane. Cyclopropane is also no more in use. It is highly combustible, so it's very unstable. It can cause explosions. So we stopped using cyclopropane 50 years ago. Okay. So these 3 agents have predominant NMDA receptor activity. Remaining drugs we'll see now. Okay. Ether, you remember it was the first successful first anesthetic agent that was used for successful demonstration of general anesthesia. Followed by chloroform. As I told earlier, it was used for labor analgesia. We stopped using it because it had like lot of reports of sudden cardiac arrest due to arrhythmias. Similarly, halothane, which is still in use in some third world countries, we have stopped using it. Halothane is a agent with fruity smell, ideal for inhalation induction, but we don't use it anymore because of risk of fatal cardiac arrhythmias. Also, it can cause fulminant hepatitis, especially in repeated exposures. Okay. Halothane is known to cause halothane hepatitis. It's a immune mediated adverse effect, and anesthetists and OT staff are at highest risk. So we have stopped using this. Enflurane is not in use anymore. It is known to be epileptogenic. Methoxyflurane, which is most potent and most nephrotoxic, we don't use it. Okay. We don't use it because it is nephrotoxic, right? Okay. Stardust is asking a question. Yes, Stardust. Nitrous oxide is an occupational hazard. So I have stopped using it. Some of them still use it, but slowly it will be phased out in our country also. Okay. So going on to the next agent, that is isoflurane. Isoflurane, remember, it's a very good agent, not so expensive, and we use it for maintenance of anesthesia, and also we use it in stable patients who are undergoing neurosurgery. But the most popular inhalational agent that Meenakshi sir was asking is sevoflurane. It has got a sweet smell, so we can use it in children for inhalational induction. Okay, so sevoflurane is a drug of choice in children. It's also a drug of choice for inhalational induction. We can use it for maintenance of anesthesia as well. So if your question says which drug can be used for both induction and maintenance, we can say sevoflurane safely. Okay, yeah. The next drug that is used is desflurane. Desflurane, as I said, is a very good agent. It causes rapid induction and rapid recovery, but we need Tech 6 vaporizer for using this. So rarely we see it being used in small hospitals. Okay, so this I told already. Can somebody answer this? Which of the following agents can be used for both induction of anesthesia and for intubation? Come on, please try. Okay, good. Is it desflurane? No. Isoflurane? No. Halothane? No, you stopped using it. Answer is sevoflurane. Okay. So next topic is muscle relaxants. As you know, these are required for producing muscle relaxation. So the muscle relaxants are classified as depolarizing and non-depolarizing muscle relaxants. Under depolarizing muscle relaxants, we have only two drugs, that is suxamethonium and decamethonium. Decamethonium being the longest acting drug, it is not in use anymore, whereas suxamethonium is a very popular agent. It's a shortest acting depolarizing agent. It gets metabolized by plasma pseudocholinesterase or pseudocholinesterase enzyme, and patients with pseudocholinesterase deficiency, that is commonly seen in a particular community called Vaishya community from the Andhra region. They have this deficiency and they cannot metabolize suxamethonium rapidly. So it's a rapidly acting drug. It's a shortest acting drug. So when you give this drug, the action sets in within 30 seconds to 60 seconds and it will last for say 5 to 10 minutes. But if the person has pseudocholinesterase enzyme deficiency, then he cannot metabolize it and he'll be stuck paralyzed for say 1 or 2 hours. Okay. Yes. So it is a choice of it is a muscle relaxant of choice for rapid sequence intubation, but it should be avoided in patients with burns and in patients with increased intracranial pressure, because it tends to increase the BP as well as intracranial pressures. In burns, it is avoided due to risk of hypercalcemia. Burns patients will already have due to risk of hyperkalemia. Burns patients will already be having hyperkalemia, and you give suxamethonium. Suxamethonium tends to increase the potassium levels, so that is additive. We avoid it there. And remember, use of suxamethonium was widespread and suddenly they stopped using it because it was known to trigger malignant hyperthermia. So remember, suxamethonium is not safe in malignant hyperthermia. It should be avoided at all cost. So we stopped using it in pediatric patients and for most of the cases in our OT. Okay, but it's a very good agent, remember. So when you give, I said earlier, when you give muscle relaxant, you have to give reversal agent. But for suxamethonium, you don't have to give reversal agent because it is already metabolized by pseudocholinesterase. Okay, yeah. So then coming on to the next set of muscle relaxants, that is non-depolarizing agents. What are these non-depolarizing agents? Okay, we classify them as short acting ones, intermediate acting ones, and long acting ones. The short acting one is gantacurium, followed by mivacurium. Okay. The commonly used ones are atracurium, cisatracurium, vecuronium, and rocuronium. Okay. So both atracurium and cisatracurium are eliminated from plasma by Hoffman elimination. What is Hoffman elimination? Okay, they are eliminated by plasma esterases. Okay, by ester hydrolysis. So they are safe in patients with liver disease and they are safe in patients with renal failure. Okay, but in patients with renal failure, you should use it with caution because in them, a metabolite of these drugs, cisatracurium and atracurium, called laudanosine, can get accumulated and it can lead to seizures. Okay, be careful while using these in renal failure patient, but it is deemed safe. Okay, yeah. And the drug that we commonly use in our OT is vecuronium. It causes minimal histamine release, therefore it is safe in asthma. Whereas in the olden days, we used to use DTC, that is a long acting agent, D-tevecurine. It used to notoriously cause histamine release, and it used to trigger acute life-threatening asthma. So we used to avoid DTC in patients with active respiratory illness and asthma. So nowadays, though, we don't get to see this DTC at all. Okay, rarely we use pancuronium. Okay, it has got a vagolytic effect and it can increase heart rate and PP, but generally we don't regularly use it. Okay, the commonly used agent, one more, that is rocuronium. Nowadays, Sugamadex has been marketed in a very uh, popular fashion. So, rocuronium, which is the fastest acting non-depolarizing muscle agent, is slowly picking up. Okay, so to tell you, rocuronium will start acting in 1 or 2 minutes of giving, whereas vecuronium takes about 3 to 3.5 minutes for providing good relaxation. So I would use rocuronium. Okay, and the effect of rocuronium will stay for similar minutes, that is 25 to 35 minutes after induction, same as vecuronium and cisatracurium or atracurium. Okay, so I'd rather use rocuronium. One more reason for using rocuronium is it is readily reversed by Sugamadex. So in certain situations we need to use rocuronium because, like, if the patient has difficult airway, instead of using scoline, I'll use succinylcholine or suxamethonium or scoline. We'll use rocuronium because it is readily reversed by a drug called Sugamadex. It's a reversal agent. I'll talk about it. And one more thing you remember, least potent muscle relaxant is galamine. Okay, and it's not available. Okay, fine. So the reversal agent, what are reversal agents? Reversal agents are the drugs that are used for reversing the action of these muscle relaxants. So there are two classes of agents. One is anticholinesterases. They are neostigmine, pyridostigmine and hydrophonium. They are often used in combination with glycopyrrolate or atropine. Whereas we also have a newer drug called Sugamadex, which I said earlier is used for reversal of rocuronium. It can also be used for reversal of vecuronium. Okay. So what it does, it goes and binds the muscle relaxant that is bound to the neuromuscular junction receptors, and it releases the agents. Okay, so that reverses the action of these agents rapidly. Okay, so what is the order of muscle blockade in case of muscle relaxants? So the first muscle to get blocked is small muscles of the face like eyelids, followed by pharynx, larynx, limbs, trunk and intercostal, and most resistant structure to muscle relaxation or muscle relaxants is diaphragm. And remember, diaphragm is the most resistant and first organ to recover from neuromuscular blockade. Okay, so remember this order. So remember a person and you can remember top to bottom. So ऊपर से नीचे, ठीक है? Eyelids, pharynx, larynx, that is vocal cords, limbs, trunk, intercostals, followed by the diaphragm. Okay. So how do you know a person is reversed? How do you know he has come out of the action of muscle relaxants? So it is by clinical assessment. So you ask the patient to open his eyes, protrude the tongue, to have a steady head lift for say 5 seconds, sustained head lift for 5 seconds with a sustained clenching of teeth, and you try to hold that person's you ask the person to hold your fingers. Okay, if he has sustained hand grip or if he is able to move his feet. Okay, and finally if he is able to cough properly, that means he is reversed. So these are the signs of reversal. So coming on to the next topic, that is local anesthetics. What are local anesthetics? These are the drugs we use for producing local anesthesia. So what they do? They produce local anesthesia. Okay. How do they act? The mechanism of action is by blockade of sodium channels. And remember the classification. Local anesthetics are classified as the esters and amides. Okay. So the esters include, okay, remember all the local anesthetics. How do you identify? They have a cane in their name. Okay, cane. Okay, CAINE, cane. Okay, all the local anesthetics have a cane. Okay, yes. So the ester linked local anesthetics have only cane. So there is no additional I in them. Whereas the amides have an extra I. There is an I in amide, therefore they have an extra I in them. So remember, this is how you remember the local anesthetic classification. Okay, so let us try to learn some important point from each of these local anesthetic. Starting with cocaine, you can remember, you can recall in the beginning of the session we said cocaine was the first ever used local anesthetic. It was the first ever used local anesthetic for spinal block, and remember, it does not undergo ester hydrolysis like other ester local anesthetics, and it can cause hypertension. Okay, next, remember two agents, procaine and mepivacaine are never used for surface anesthesia. Okay, then chlorprocaine is the shortest acting local anesthetic. Okay, accidental intradural injection can lead to paraplegia. Which is the longest acting ester? It is tetracaine, and it can cause ventricular fibrillation. Which is the most commonly used local anesthetic worldwide? It is lignocaine. So if you go and check in any OT or any ward, you will see a vial of lignocaine. So it is there everywhere. It is the most commonly used one. It is used for producing IVRA, and it can cause neurotoxicity. Okay, remember, toxicity of lignocaine presents with CNS features. Okay. Prilocaine is considered the safest local anesthetist, and it also produces methemoglobinemia to the highest extent. Okay, bupivacaine, the second bupivacaine is the second commonly used agent. It is most commonly used for central neuraxial blockade, that is spinals, and for producing epidurals and regional blocks. It is cardiotoxic. So the toxicity features of bupivacaine will be like more of cardiotoxic features. Okay, yeah. Next agent is ropivacaine. Ropivacaine is similar to bupivacaine, it's an analog, but it is less cardiotoxic and safer, but the effects are similar to that of bupivacaine. And there is another drug, classical drug called the dibucaine. It is the most potent amide local anesthetic. It is the longest acting local anesthetic, and it is also the most toxic local anesthetic. There is something called as a dibucaine number. Dibucaine number is nothing but the percentage of pseudocholinesterase enzyme activity inhibited by dibucaine. So the normal number may be around 70 to 80. Okay, but I said earlier, patients with pseudocholinesterase deficiency, in them dibucaine number will be less than 20. Okay, you don't have to remember the exact number, just try to remember the range. Okay, it will be between 10 to 20. Okay, less than 10 to 20. Fine. So the last agent for the day is etidocaine, which is highly potent long acting local anesthetic. So as I said, local anesthetics can get absorbed into systemic circulation, and they will lead to systemic toxicity, producing local anesthetic systemic toxicity. They can produce CNS symptoms like mild CNS symptoms like circumoral numbness, metallic taste, restlessness, followed by transient symptoms like tremors, leading to toxic symptoms like seizures and causing coma and even cardiac arrest due to arrhythmias. So they can come with CNS toxicity or cardiac toxicity. Remember, lignocaine causes CNS toxicity more. whereas bupivacaine causes cardiotoxicity. How to remember this? BDLC. Okay. So B is bupivacaine, cardio has D, so BD, LC. L is lignocaine, C is CNS. BDLC. Okay. Yeah. And remember, two drugs that are derivatives of PABA, that is prilocaine and benzocaine, can cause methemoglobinemia. They can also cause allergy and anaphylaxis. So what to do when there is last? So you have to tell the surgeon to stop the surgery immediately. You have to give 100% oxygenation, give manual ventilation, and maintain the oxygenation and ventilation. If there are seizures, give drugs to manage the seizures. If there are features of cardiotoxicity, like if there are arrhythmias, try to treat it. Simultaneously, remember this agent, 20% intralipid. So if you have this in your setup, so infuse 20% intralipid. Loading dose of 1.5 mg per kg over a minute, and you can repeat the bolus if there are persistent symptoms at a rate of 30 mg per kg per hour. So shift the patient to ICU to manage better. So coming on to the questions, this will be a rapid fire thing. So as I said, okay, we have taken 10 minutes more. Fine. So what is the mechanism of action of local anesthetics? Okay. What is the right answer here? Sodium, potassium, calcium, chloride. Which one? Yes, the sodium. Okay. Which drug causes hypertension? Remember from the list. Is it lignocaine, bupivacaine, cocaine, or prilocaine? Yes, the answer is cocaine. So Stardust is asking me, does halothane cause malignant hyperthermia? Yes, Stardust. Actually, all the anesthetic agents can cause malignant hyperthermia, in which case we generally, when there is a episode of malignant hyperthermia crisis, we stop all the agents that patient is receiving. Okay, mainly the inhalational agents and muscle relaxant like scoline are notorious for causing these. Whenever there is an episode, we try to stop all the inhalation agents. Okay, instead we switch over to IV, which are considered safer in case of MH. Okay, and we manage the patient symptomatically. And whenever there is a malignant hyperthermia crisis, we are supposed to give a drug called dantrolene sodium. Remember this fact. Okay, fine. Going on to the next question. Can someone answer this? During resuscitation, a patient has received 20% intralipid injection, IV. What is the most probable diagnosis? Okay, 20% intralipid. Where we give? Correct. Local anesthetic, systemic toxicity. Okay. Coming on to the last bit of this pharma topics. Topical anesthetics. What are topical anesthetics? These are the local anesthetics mixtures or the agents which we apply topically on the skin and mucous membranes to produce numbness or anesthesia that is limited to that area. So this is useful in minor OPD procedures like IV cannulation or some eye procedures like gonioscopy. Even cataract surgery can be done under topical anesthesia. So let us see what are the commonly used topical agents. First one is EMLA. What is EMLA? EMLA is a mixture of eutectic mixture of 2.5% lignocaine with prilocaine. It is applied about 1 to 2 gram is applied about half an hour to 1 hour before pediatric IV cannulation. So it provides a topical anesthesia that can be 5 mm deep, that is half centimeters deep, and it will last for about 2 hours. So EMLA cream you are going to use for pediatric IV cannulation. Okay. Yes. You have also seen we use lignocaine jelly in and out. Okay, for all scopies, even for catheterization, etc. We also have the lignocaine spray, aerosol spray. Okay, so it is available as 2% gel and 4% or 10% aerosol sprays. So it is useful for all the short OPD procedures. It can also be used for IV cannulations. Okay, remember it can be used like EMLA. So if in your setting, if there is no EMLA cream, you can use the lignocaine spray that is available. It is equally good. But remember, you have to apply the spray or the gel 1 hour before the planned IV cannulation. Okay. Yes. So we have something called as a proparacaine. Okay, it's an eye drop that can produce topical anesthesia within 2 minutes. Okay, very rapidly acting. It is useful for all the eyes procedures like gonioscopy, cataract, foreign body removal, etc. It has got a rapid onset of action and it is short acting. So its action is also short lived. It will last for about 15 to 20 minutes. Okay. Yes. So when they're seeing a patient in the OPD, they would have put the drops, they would have examined and they would have done some tests. When he goes to the OT, again they put these drops. Okay. Yeah. So what are the constituents of EMLA cream? We saw this. It's a 2.5 mixture, 5% mixture of, correct, lignocaine and prilocaine. And action of proparacaine starts in 2 minutes. Good. Coming on to the next important topic, this is pain management and palliative care. It's a very important topic. It's a upcoming topic for your exams. Last exam had some 4 or 5 questions from this topic, imagine. So important concepts in this chapter are pain pathway and pain models, modulation of pain, pain assessment and management of chronic pain, opioids, palliative care and analgesic ladder. So we'll try to just spend 1 minute on each of these. We'll try to finish this quickly. Okay, so how do we feel the pain? So we receive pain from due to painful stimuli or the noxious stimuli. It can be chemical stimulus, thermal stimulus, electrical stimulus, or a mechanical stimulus. Chemicals like acid or anything. Okay, even acid or some spice. Okay, okay. There is, what is this? Okay, this is some seaweed extract. Okay, why have I written this here? Okay, in some experimental studies they use this seaweed extract, and this seaweed, by the way, is called carrageenan. Okay, so this one, in experimental models, on application of this powder, it produced pain. Just remember that fact. Okay, coming on to this later. Yeah, so there are these painful noxious stimuli. They cause tissue damage. Okay, and this damage is picked up by the nociceptor, and the pain impulses are carried through the nerve by transduction and transmitted to the spinal cord level through the by transmission by A delta and C fibers. Remember, A delta and C fibers will carry the pain sensation. Okay, yeah, and while this pain is being carried from periphery to spine and above, it can be modulated. Okay, yeah. What is modulation? Modulation is regulation. Fine. So once the pain impulse is taken to the higher centers, there it is perceived and the signal is sent for reacting. Where do we perceive the pain? At the level of cerebral cortex. So there is stimulus, there is tissue damage, then there is impulses that are carried by spinal cord and the tracts. What tracts? Lateral spinothalamic tract, and it is taken to the brainstem, and from there it is projected to the cerebral cortex where it is felt. Okay, so the same picture, but I have put something extra here. So as you can see, I have written about modulation. What is modulation? Regulation. I said that time. So when it is being carried up, okay, at the level of spinal cord, we can have a gate. Okay, this one, or here somewhere we can have a block. So if you can block that particular area using local anesthetic, okay, or using topical NSAIDs or local anesthetics, etc. So you can regulate the pain, or if you can devise any technique that can modulate the pain at this level, so you are going to prevent the pain from going up. Okay, this is called the gate control modulation of pain. Okay, based on this, TENS, what is TENS? Transcutaneous electric stimulation of the nerve. This device was devised based on this gate control theory. Okay, pain can also be modulated at different levels. It can be stopped by segmental inhibition, like how you given spinal or something, okay, by injecting local anesthetic, opioid, or alpha 2 agonists at the spinal cord level. You can cut off the pain. Patient will stop feeling pain below the level where which you have injected these agents. Okay, that is segmental inhibition. And also you can have endogenous opioids like endorphins, which will make the patient feel good even though he is in pain. Okay, and the pain that is descending from the higher centers can also be modulated by many techniques. So remember, modulation of pain is a very important concept. New questions are expected to come from this topic. Please focus on this topic. Okay, so this was the latest question. As I mentioned earlier, the Karaginin model of pain involves application of which of the following to the tissues. Okay, so what was it? Seaweed. Remember, it was a chemical. Okay, yeah. One more question that I said, TENS. What is the mechanism behind TENS? This is a repeat question. It has repeat question. It has appeared like 3-4 times before. So TENS, is it descending inhibition? No. Central inhibition? No. Sensitization? No. So the right answer is gate control theory. So how do you assess pain? It is assessed with the help of tools. There are unidimensional and multidimensional tools. Questionnaire is a multidimensional thing because it will ask multiple. It is focused on multiple things. So it will ask you multiple details. Whereas unidimensional, that is, you are just asking the patient the degree of pain. So what is the scale that is preferred in children? Remember, it is FACES rating scale. So pain assessment tool for children, FACES rating scale. Pain assessment tool that we most commonly use in our post-operative setting, that is visual analog scale. In this, we ask the patient to rate the pain from 1 to 10. Okay, where 10 being maximal pain and 0 being no pain. Okay, remember. So what are the pain management strategies? So you have to manage the pain post-operatively or in the ICU. So the main strategies include non-drug strategies, regional blocks, and pharmacotherapy. In this session, we'll just focus on opioids. Okay. So quickly, let's recall. Opioids are derived from poppy seeds, and they can act on 3 receptors, opioid receptors, that is mu1 and 2, kappa and delta. And opioids can be synthetic like morphine, codeine, thebin, and papaverine, or they can be semi-synthetic like apomorphine, oxycodone, buprenorphine, etc. And they can be synthetic like fentanyl, alfentanil, sufentanil, remifentanil, pethidine, tramadol, etc. But the important classification for us here is based on their action. So the drugs that are pure agonists at opioid receptors are morphine, pethidine, fentanyl, and alfentanil, sufentanil, and remifentanil. These are the agents that are pure agonists, and they are useful in blocking the opioid receptors, and they are having highest analgesic property. Okay, so the morphine is a prototype opioid. It is used for severe pain of acute conditions or chronic carcinoma related pain. It produces sedation in patients. It is available as IV formulation as well as tablets, and it can cause histamine release. That is a side effect of morphine. So what does histamine release lead to? It can cause pruritus. That's all. Okay. And what is the most severe adverse effect? It can cause all the opioids, remember, they can cause respiratory depression and can lead to coma or death. So the second drug here is meperidine or pethidine. We don't use it now, but it was very popular in the yesteryears, especially after deliveries, and it is also useful for preventing the shivering after in the post-operative period. We stopped using it because of its neurotoxic metabolite called normeperidine. Okay, yeah. So also better drugs are there in the market now, like fentanyl. It is 100 times more potent than morphine. It is available as transdermal patch. It is available as IV formulation, etc. Remember, it can cause dose dependent respiratory depression, and it can lead to rapid, it can lead to chest wall rigidity when it is given rapid IV. Okay, rapid IV injections of fentanyl associated with chest wall rigidity. And alfentanil and sufentanil and remifentanil are all analogs of fentanyl, derivatives of fentanyl. They are all short acting, ultra short acting. Okay, and remember, sufentanil among them is the strongest. It is ultra potent and it has got 500 times the potency than that of morphine. It causes less histamine release. Okay, but remifentanil, please remember, you can expect some questions from remifentanil because it is being marketed widely all over India, and I'm sure most of us have started using it. It is an ultra short acting drug and it gets rapidly metabolized in the plasma by the plasma esterase. What is plasma esterase metabolism? It is Hoffman elimination. Okay, remember that. Okay, yeah. So as I said, opioid toxicity can lead to severe respiratory depression. Also, it will lead to central nervous system depression with characteristic pinpoint pupils. So anyone with opioid toxicity will present with this. So this can be reversed by naloxone. What is naloxone? Yes, naloxone is a pure opioid antagonist. Remember. Okay. So one more point I want to tell, that is some opioids. Okay, their metabolism can be interfered due to patient taking some other drug, like patient if he's on SSRI like fluoxetine, which is used for depression, it can interact with the opioids. Fluoxetine is metabolized by liver. Okay, and opioids which are also metabolized by the liver, like cytochrome P450 or 2B6 or 3A4. Okay, these can be inhibited. This metabolism can be inhibited if the patient is taking fluoxetine. Okay, so there is accumulation of these opioids. So for example, methadone. Okay, this is, I'm telling this because it is characteristically seen with patients on methadone. Okay, so patient will be having some painful condition for which he'll be receiving methadone, but he also may be depressed, so he's put on fluoxetine by the psychiatrist, and unknowingly patient is getting these two drugs from two different people, and this has led to increased level of methadone. So this will trigger something called as serotonin symptoms. Okay, increased levels of methadone will lead to serotonin syndrome symptoms. What are the symptoms? Palpitation, arrhythmia, syncope, stupor, etc. Okay, yeah. So this question is designed based on that. This was asked in your INI-CET. Okay, so we have a 48. Try to answer this. We have a 48-year-old with depression on fluoxetine, comes to emergency with palpitation, arrhythmia, one episode of syncope. So what is he having? Yes, he's having serotonin syndrome ka symptoms. Okay, yeah. So he is also on an opioid medication for chronic pain. Okay, so which of the following agents may he be taking? Yes, you read this. methadone. Okay. Yes. Okay. So this is a fresh question. Can you answer this? Which of these agents is not metabolized by any organ in the body? Any organ by when they say it is usually liver. Okay. Okay. Liver metabolizes most of the drugs or anything you're taking. Yes. How does it get metabolized there? By conjugation, oxidation, transformation, biotransformation, etc. Okay. Fine. So which of these drugs doesn't undergo any of those? Is it mecuronium? No. You've seen that it is metabolized by liver. Thiopentone? No. Saxamethonium? Okay. Saxamethonium? Yes, it could be the answer. Remifentanil? Yes, it could be the answer. So this question has two answers. Okay. But since we are discussing opioids, I'll stick to remifentanil as the option. If it comes in your exam, you can mark both remifentanil and saxamethonium as the answers. Okay. Fine. Coming on to the last bit, drugs that are used for chronic pain syndromes. Just remember, post-herpetic neuralgia, diabetic neuropathy, then spinal cord injury, fibromyalgia, HIV neuropathy, all these are long-standing chronic conditions. So you will have to give some drug. Obviously, they'll have depression. So you will use some drug that will deal with both, centrally acting. Okay. So remember, we can use gabapentin or pregabalin. We can give antidepressants. Okay, we can give opioids like tramadol or lignocaine patch. Okay, yes. So same thing for diabetic neuropathy, pregabalin, gabapentin. Okay, duloxetine or antidepressants. Okay, again pregabalin, gabapentin. Okay, okay. If you are still listening to me, can somebody answer in the chat box which famous actress had fibromyalgia recently and got treated and doing well now? Okay. I won't answer this. This won't come in your exam. Fine. Okay. Remember, so pregabalin and gabapentin are the answers for most of the chronic conditions. These are the drugs that are commonly used in most of the chronic conditions. So the question here that was asked was, uh, which drug is used for diabetic neuropathy, post-herpetic neuralgia, and spinal cord injury? So I said two drugs, right? Yes. Okay. Coming on to the last bit, that is palliative care. What is palliative care? Palliative care is providing care to a person who's chronically sick or terminally sick. Okay. So the principles of palliative care include improving the quality of life, managing the symptoms like pain, providing support to both patient and family. Remember, it does not affect the life expectancy. It does not provide a cure for the patient or for the illness. It does not prescribe any euthanasia, especially in India, in Indian setting. Okay, fine. So what do? We give painkillers. So there is a WHO ladder that was given by WHO in 1986 or something. So it advocates analgesia by mouth and by time. Okay, and depending on patient's needs. So if there is mild pain, we start with some basic analgesic like aspirin, paracetamol, or any NSAID. You can consider adding adjuvant if it is not enough, or you can make two mild analgesics for a mild pain. Okay, yeah. So if that is not cured, you are going to add an opioid, a less potent opioid like codeine or oxycodone, okay, or tramadol along with the adjuvants. But if your patient complains of severe pain, then you should consider giving morphine or fentanyl patch or morphine tablet, okay, or any of these agents along with what you were given earlier. So stepwise, okay, you have to give. So what are the adjuvants you can consider? If your patient has a bone pain, consider giving calcitonin and bisphosphonates. Also, you can consider giving gabapentin or antidepressants in patients with neuropathic pain. So coming on to the question, tell us which are correct statements with respect to palliative care in India. It involves providing complete cure to illness. Does it? No. It involves prescribing active euthanasia. No. It improves the quality of life of patient. Okay. It involves prescribing of analgesics to relieve the cancer pain in patients. Correct. It neither increases nor uh, it neither increases the life expectancy nor decreases it, and you cannot let the patient suffer, so you have to do something. Is it right? No. So what are all right here? This was right, this was right, and this was right. So the answer here is this one. Okay. Yeah. So coming on to the next chapter, we'll go very rapidly. I know you're getting bored. Okay. Abhishek Jha says hi. Okay. Hi, Abhishek. I know I've taken a lot of time. My idea was to cover as many topics for your exams because, as you all know, today the NEET PG forms have come. Most of you must be busy applying for it. If you didn't know, this is a news for you. I started the session with this news. Okay, so if you haven't applied, try to apply and prepare well. My idea was to cover as many topics as possible in this session. Initially, it was a plan of 2 hours class. It might get extended a little bit, maybe 2.5 or 3, but I want to finish major topics so that it is easy for you to go back and go through the notes and you're done. Okay, you don't have to worry about anesthesia after this. So let us continue. And by the way, this is not just for INI-CET. I've covered the topics that have come in NEET PG as well. So we'll have another session later someday where we'll discuss all the MCQs. But kindly go through this video if you are not watching live. Go through the video till the end. Okay. I'm going to discuss some strategies also towards the end. Fine. So the next concept we are going to discuss is gas flow system, patient safety and patient monitoring. Okay. So in this we are going to see hospital pipeline system, cylinders, patient positioning, IV access and monitoring. Okay. Yeah. So the components of gas flow system, as you know, there will be a source of gas. It will be carried to the point of care through the pipeline system, and there we'll connect the machine, and through the breathing system we are going to give it to the patient. Okay. So from the patient, the gases are sent out by the scavenging system. This is how the flow is. Okay. Yes. So the commonly used gas sources are oxygen or air or nitrous from the generation plant, or from the liquid storage tank, or through the cylinders. So the color coding, remember this was asked in your exam. Oxygen is carried by white pipeline. Medical air is carried by the black pipeline. Nitrous oxide is carried by the blue pipeline, and vacuum carries the yellow pipeline. Okay. Try to remember this. This was asked once. So, okay, tell me white oxygen, air black, nitrous blue, and vacuum yellow. So if you have gone to the operation theater or to the ICU, you would have noticed these pipes. So you will be wondering what did you see there. So next time you go there, try to recall white is oxygen, black is air, blue is nitrous, and yellow is vacuum. So the next concept is pin index system. Pin index system is a safety feature on anesthesia cylinders to prevent mismatching or misattachment of wrong cylinder to the machine. So as you can see, there are pins on the machine. Here there will be pins. This is the machine actually, and on the neck of the cylinder there are holes or the grooves. Okay. So these grooves are different for each gas. So for oxygen, it is at the positions 2 and 5. So 2 and 5. For nitrous oxide, it is at the positions 3 and 5. 3 and 5. Okay. For air, it is at the positions 1 and 5. And for carbon dioxide mixture with oxygen, it is at the position 1, 6 or 2 and 6, depending on the oxygen or the carbon dioxide content. Entanox, the pin index number is 7. Remember the color coding. If you remember, among these very important ones are nitrous oxide, which is blue. Earlier the whole cylinder used to be blue. Nowadays we are getting white cylinder with blue shoulders. Oxygen, earlier we used to get black cylinder with white shoulders, whereas nowadays we are getting white cylinders. Okay, remember these two, nitrous and oxygen. These are very commonly used in the OT. Okay, and also for laparoscopic surgeries we are using carbon dioxide. So that is a gray cylinder, and medical air is gray cylinder with black and white shoulders. Okay, yes. So let us recall, what are the blue line meant for? Yes, nitrous oxide. Okay, coming on to the next concept, that is patient positioning. So can you identify this patient position? Okay, so the answer here is Trendelenburg's. So what are the different patient positioning patient positions you know of? So this is supine. Patient is lying flat. Most of the surgeries are done in the supine position only. Some surgeries we have to put the patient upside down, that is prone. So prone surgeries, prone positioning is used for spine surgeries mainly, especially the surgeries where we need the posterior approach. This is lateral position. Lateral position is required for, say, some renal surgeries. What is this one? Head low is, as you can see, this is the table level. Head is lowered here by 15 to 30 degrees. Okay, so this is called the Trendelenburg position. So when the head, instead of coming down, if it goes up, it is called reverse Trendelenburg. Okay, fine. So where do you use the Trendelenburg position? We use it in some laparoscopic surgeries where the surgeon wants to visualize the structures. Okay, yeah. Then what is this? If you have entered labor room, you will know this. This is lithotomy position. So most of the gynecological procedures in labor room, that is D&C or even the delivery, are happening in the lithotomy position. So what is this? Okay, this is as if somebody is sitting and driving a car, right? Yeah, so this is a sitting position. So where do we use this? We use this in craniotomies, also in the clavicle surgery. Sitting position is also known as the beach chair position. As if he's relaxing on the table. Okay, yeah. So this is what, this is somebody put upside down and he's bent like a clasp knife. Okay, so it is jackknife position. Okay, yeah, this is used in anoscopies. Fine. Coming on to the next concept, you have taken the patient inside the OT, and first thing you are going to check is IV access. So IV access is by inserting IV cannula. So we have different sizes of IV cannula starting from 14 gauge to 26 gauge. Each of them are indicated in different conditions and different patients. So 14 gauge is orange, then gray, 16 is gray, 17 is white, 18 is green, 20 is pink, 22 is blue, 24 is yellow and 26 is purple. How to remember this? Okay, remember the Indian flag, sorry, Indian map that is shaded like this. Okay, so first there is orange. Okay, that is 14. Then there is slight gray tint shade. Okay, that is 16. Then there is white, that is 17. Then there is green. Okay, lot of greenery, right, in south. So green, that is 18 gauge. Okay, got it. So remember India's first pink ball cricket match. Okay, yeah. So pink ball, pink is 20. Okay, yeah. Ball, B, blue. Okay, that that was held on a yellow pitch. Okay, India's first pink ball cricket match was held on a yellow pitch. Yellow is 24 and pitch is purple. I hope I have made it a little simpler to remember. Try to remember this picture and try to remember the India's first pink ball yellow match was held on yellow pitch. Okay, yeah. So by the way, they'll not ask you what is the pink ball match. Okay, so pink ball is used for day night test matches. Remember, okay, it started in Australia. Yeah, fine. So different uses, different sizes of cannulas. So orange, gray, and white, these are all large flow rate cannulas. They are useful in trauma and large transfusions where we require rapid fluid replacements. Green is used for blood transfusion and for large volume transfusion, and whereas pink is a multi-purpose cannula. All these are commonly used in adult patients, whereas in children we use the blue. In case of newborns we use the yellow, and in case of neonates and preterm newborns we use the violet. Okay, so elderly patients also have fragile veins, so 24 or 25 can be reserved for these guys as well. So if the venous access is not available, we'll have to put a central line, that is central venous access. It is done either by a internal jugular route or a subclavian route or a femoral route. Okay, internal jugular is the easiest. Subclavian has least chances of infections. Femoral has higher chances but easy to put. It can be easily put during emergencies. Okay, yeah. So this is a central line set. So what are the complications that you can expect while putting the central line? Catheter can get malpositioned. You can cause bleeding or hematoma, okay, which can lead to thrombosis. You can hit the lung pleura. You can cause pneumothorax. You can have mechanical complications like kinking of the cannula or obstruction, etc. And it can be associated with catheter related infections. Okay, so at the time of entry, which is a most commonly seen complication at the time of entry? It can be malposition, or more than that, it can cause bleeding. Okay, remember that. So let us recall, what is the size of pink cannula? I told no, pink ball. Okay, pink I told, right, 20. Yeah. So which of the following is used in a preterm newborn? I've told this 26. Immediate complication during central line insertion? Yes, injury to the vessel, that is arterial injury. Okay, next concept is monitoring. So when I say monitoring, monitoring is a very essential part of any surgery. So the American Society of Anesthesiologists has told that ECG, NIBP, SpO2, that is pulse oximetry, and end-tidal carbon dioxide when temperature monitoring are a compulsory thing for every case. These are the standards for any case. Okay, any case can't go without having an anesthetist around and these parameters being monitored. And you can also have some desirable monitoring like depth monitoring, carbon cardiac output monitoring, and neuromuscular monitoring. Okay. Yeah. So I'll just tell one point about each. ECG. Okay. You know that we use in the OPD setting 12 lead ECG, but in the OT 3 lead or 5 lead ECG is enough. So on lead 2, we can spot all the arrhythmias, whereas in anterior leads, that is V4 or V5, ischemia can be easily detected. Okay. So this is a multi-para monitor that we usually see in our OTs. So we also monitor the pulse. We also monitor the SpO2, that is oxygen saturation in the arterial blood, by pulse oximetry. It's a non-invasive method by a fingertip probe. What it does, it measures the percentage of hemoglobin in the arterial. It tells us how much percent of hemoglobin in the arterial blood is saturated with oxygen. Okay, so the normal range of SpO2 is anywhere between 95 to 98%. 100 if you have, it's too good. And anything below 93 needs your attention. Below 90, tissues become vulnerable to hypoxia. So you supplement oxygen. Supplement oxygen doesn't work, still under 90, then you may have to ventilate the patient. Okay. So remember, pulse oximetry works on Beer-Lambert's principle, where LEDs that emit two wavelengths like 650 and 940 emit the light. It is caught by a photodiode and impulses are sent to the chip, which using algorithm gives you the number. Okay. So the light travels across the vessel, and some light will get scattered, some will get absorbed. Finally, whatever passes through is caught by the photodiode, and the information is sent for processing. Got it? I've simplified it. Yeah. So the reading can be affected by presence of any abnormal hemoglobin, presence of poor peripheral perfusion, hypotension, anemia, shivering, and presence of nail polish. Okay. Yeah, the girls are very fond of nail polish, right? Especially presence of blue, purple, and black nail polish affects SpO2 reading highest. Blue being the worst. Okay. Yes. So your patient, if she's wearing blue nail polish, get it removed. Yeah. So next monitor is capnography. So it's a non-invasive method to measure the carbon dioxide concentration in the exhaled breath. Okay. It gives the CO2 concentration in the alveoli at the end of expiration, and it's a waveform representation of this expired CO2. So this is how a normal capnogram looks like. So this is phase 0. Sorry, this is the baseline, that is almost near the baseline, and this is phase 1, and this is phase 2, and this is phase 3, and then there is phase 0. So the norm, I'll come to that in detail. So the normal and normal PaC2 values are between 40 to 45, but when the patient is expiring, in the expired air, the CO2 concentration will be 35 to 45 millimeters of mercury. Okay. So I was talking about the capnogram. So phase 1 is the baseline. Okay. So here the patient has already finished expiring and is about to start breathing. So this is the baseline. Here the patient is about to start breathing. So it is 1, or I stands for inhalation. Okay. And patient is breathing in, so there is no carbon dioxide going out. So EtCO2 is 0 here. Okay. Fine. Just at the beginning of exhalation, so patient has taken the breath in and is started to breathe out. So that is phase 2. Just at the beginning of exhalation, the gas that is there in the anatomical dead space first comes out, along with the gas in the lower ones, lower alveoli. So this is just the beginning. So the graph will slowly peak. Okay. And it goes up and reaches a plateau where it is continuously receiving the gas from the alveoli. So finally, at the peak, you will see the highest measurement. Okay, this is where they take the this peak. Okay, this is where they take the EtCO2 reading. Remember? Okay, and when the patient starts breathing again, you will see the downstroke. That is phase 0. Fine. Yes. Coming on to the typical capnograms we see. So this is a normal capnogram. Here we are seeing square forms. Okay, this is seen in controlled ventilation. But if your patient is breathing on his own, like spontaneous ventilation, this is how you will see. Okay. Yeah. So your patient was breathing normally and under controlled ventilation. He was under controlled ventilation and he was breathing by the machine, controlled ventilation. And if he starts breathing spontaneously, you'll see a cleft. Okay. So he's trying to breathe. He's trying to inspire here. Okay. So here what you're going to see is a cleft. So this is what phase? This is a plateau phase of expiration. But here your machine is giving him expiration, but the patient is trying to breathe in. So you will see a dip. This dip is due to spontaneous effort. It's called the curare cleft. So when does this happen? When the patient is under mechanical ventilation, the effect of muscle relaxant has worn off. So you will see the patient breathing, spontaneous effort lead to the cleft. So it's called the curare cleft. So when the patient starts breathing deep or when the patient breathes slowly, you will see the taller graph and you will see the less number of waveforms, square forms or whatever. Okay, so this is a scene, this is a tracing of hypoventilation in a patient. So if your patient is breathing rapidly, so you'll have multiple waves. Okay, so this is seen in hyperventilation. So in case of asthma or sudden attack of COPD, you will see that there is obstruction to free flow of the air and you will see the sharp fin like appearance on the capnogram. So your patient is undergoing surgery and suddenly you will see that the EtCO2 value is showing 0. What you will do? First thing you are going to check is whether the EtCO2 module is connected or not. Sudden disconnection can lead to, see, the normal square forms and suddenly it has become flat. So it can be due to sudden disconnection or due to sensor malfunctioning. This is possible. Or if everything is all right, then you have to start thinking why this happened. It can happen in massive pulmonary embolism, venous air embolism or CO2 embolism, fat embolism, or if your patient who was recovering from arrest suffered rearrest, or if your patient suddenly arrested during surgery, you can see this picture. Okay, so I said about arrest, rearrest and all. No, so let me tell you, when you're giving CPR and if you're intubated and if you're seeing regular square forms like this with a value of 10, with a reading of 10 on the monitor, that means your CPR is effective. Okay, and when the patient comes with your continued effort, if the patient comes back to consciousness, that is return of spontaneous circulation, you will see a square form of 20 millimeters mercury. This means patient has slowly recovered. Okay, and your CPR has paid, was very effective. Okay, fine. While intubating, if you put the tube in esophagus, you will not see a regular square form and you will see this picture. So initially there will be some carbon dioxide that is be there in the fundus and ultimately it is going to become flat. No carbon dioxide coming out from the stomach. So you will see this tracing. So coming on to the questions. So they have given a monitor here. You're working in a recovery room. Patient is shifted out from the OT with ET tube in situ and connected to a monitor. Try to answer this. Okay. So what is the tracing in yellow they're asking? So what is this? Capnogram. Good. So next question is, a 68-year-old undergoing surgery. During surgery, he's undergoing lap surgery. Okay, I don't know why they've given this. He has a sudden fall in BP to 80/50. ETCO2 has dropped. Saturation has dropped. Okay. So what could be the diagnosis here? So okay, bronchial intubation. Bronchial intubation means a patient is intubated properly, but it has gone a little deeper. Okay, so ETCO2 should not drop there. Okay, so this is ruled out. Okay, then CO2 embolism. This we discussed that time. It could be the answer. Pneumothorax, no. Okay, pneumothorax doesn't affect ETCO2. Okay, and bronchospasm. As you saw in bronchospasm, there will be sharp finning. Okay, may not be this. So the answer here is CO2 embolism. Okay. Okay. Remember this slide. What were the techniques that we commonly use for cardiac output monitoring? Okay. We have the invasive techniques and the non-invasive ones. Non-invasive ones are usually the echo and bioimpedance, transthoracic echo and bioimpedance. Whereas the invasive ones, we generally use in the ICUs, are pulmonary artery catheter, pulse analysis, transpulmonary thermodilution, esophageal Doppler, and transesophageal echo. Okay, this can come in NEET. Please remember this slide. Okay, coming on to the very important concept of depth of anesthesia monitoring. So the anesthesia depth can be monitored using clinical techniques and monitoring the brain activity. Clinical techniques include PRST method and isolated forearm technique. The brain activity monitoring techniques are EEG based ones and evoked potential based ones. Among these, somatosensory evoked potential, visual evoked potential, and auditory evoked potential I'll come to this later. Before that, we'll see what are the EEG based ones: bispectral index, narcotrend, and entropy. These three are the EEG based ones. Bispectral index has come in your exam 2 to 3 times. Please focus on this. Okay. Then entropy, it can come in your exam. Okay. This is based on EEG as well. So coming on to bispectral index. Bispectral index is a depth of anesthesia monitoring tool. It is an algorithm based real-time intraoperative EEG interpretation. Okay, so the person is connected to the device using these sensors, it is EEG leads, which are applied over the forehead. Patient is anesthetized, and you will be seeing the BIS value on the monitor. So if the patient is anesthetized properly, at the ideal depth, the BIS value will be 40 to 60. Remember this fact. If the patient is completely awake, the BIS value will be 100, and when the patient is in coma, the value is 0. Entropy is another depth monitoring tool based on EEGs. So how do you measure the depth of anesthesia? How do you monitor the depth of anesthesia? It is by BIS. Okay. Coming on to the thing that I was saying earlier, evoked potential based monitoring. So it's a non-invasive method. What it does is it monitors the electrical activity in certain areas of brain in response to stimulation of some sensory or motor neural pathway. It is influenced by anesthetic agents, and there are three commonly used ones: SSEP, VEP, and AEP. In this, auditory evoked potential monitoring is a gold standard method. Okay, in this, three waveforms are there. That is not so important. The most important one, which I have not mentioned in this three, is the muscle evoked response measurement. MMG is the gold standard, and acceleromyography is most commonly used method of muscle evoked response measurement. These are used along with neuromuscular monitoring to know whether the patient has reversed from anesthesia or not. Okay, this is a very important tool, and as per recent most ASA guidelines, that is 2023 guidelines, uh, uh, muscle evoked response measurement is considered indispensable part of assessment of reversal in a patient. Okay, yeah. Coming on to neuromuscular monitoring, as I said earlier, it is used for assessing the function of neuromuscular junction, and it is done using a nerve stimulator and a monitoring device. So the nerve stimulator is used for stimulating some particular nerves, like most common one is ulnar nerve here for the adductor pollicis, which adducts the thumb. This is the most common one. Okay. Other sites include orbiculus oculi and posterior tibial nerve. So how does it work? Here we give an electrical stimulus to the nerve, and muscle will produce a response, and it is screened or measured using a device. This technique entirely is called the neuromuscular monitoring. So how to give the stimulus? So stimulus is a very important part of neuromuscular monitoring. So we have three types of stimuli. Okay, so let me come to that. Okay, so to stimulate a nerve, you need to give a stimulus. Fine. So I have something for you. Since this is an IPL season, I thought let's play some cricket. Okay, so did you hear that? Not so loud, right? This you heard? Okay, so this was a single stimulus. Okay, so we call it a single twitch. So when a peripheral nerve is subjected to a supramaximal stimulus in a form of single square wave, it will elicit a response. It's a twitch. So since it's a single stimulus, it's a single twitch. Okay, yeah. So if you don't apply supramaximal stimulus, beginning I said no, I in the beginning I didn't make so much noise, so that was not heard. Oh, so to produce noise, you have to give a supramaximal stimulus. Okay, yeah. So that is a single twitch. So when you apply multiple supramaximal stimuli at a frequency of 200 to at a frequency of 50 to 200 over a period of 5 seconds, like this. So sustained supramaximal stimuli over a period of 5 seconds at a frequency of 50 to 200, it's called a tetanus. Okay, so it will elicit a response from the muscle. Okay, and if you apply 2 bursts of tetanic stimulus like this, okay, so did you notice I gave 2 bursts of stimuli, burst containing 3 or 2 impulses, okay, which were repeated at an interval of 20 milliseconds. Okay, sorry, 750 milliseconds. It is called double burst stimulation. So there are 3 patterns of stimuli. One is tetany, other one is double burst, and the last one is train of 4. This is the most important. So 2, 3, 4. So I have applied 4 supramaximal stimuli at a frequency of 2 hertz with an interval of 0.5 seconds between each stimulus. So I have given 4 stimuli over a period of 2 seconds. Okay. So I'll repeat this every 10 seconds. So I've given 1, 2, 3, 4. And I'm going to repeat it after 10 seconds again. 1, 2, 3, 4. So I'm going to measure the response. So if the response here is, how to measure the response here? It is measured by measuring the height of the, so this was the first, so second, third and fourth. Train of 4. Okay, so we measure it by measuring the height of the fourth response to the first. Okay, so if this ratio is more than 0.9, it is safe for extubation. So if it is less than 0.9, that means there is inadequate recovery. So remember this, forget all that I've said till now, just remember these guidelines. What are the guidelines, what are the indications for extubation? When can you extubate? Okay, so when the TOF ratio is more than 0.9 or more, if it is accompanied by muscle myography, and if you have used adductor pollicis muscle for neuromuscular monitoring. Okay, so always use adductor pollicis muscle, always use MMG, and with all that, if you have had more than 0.9 of TOF ratio, then you can extubate. Okay, yes. So these are the standards. ASA expects you to have neuromuscular monitoring on abductor pollicis, use of MMG, and measuring the TOF ratio, train of 4 ratio. Okay, that completes the topic of monitoring. Coming on to the next concept. So we are looking at an image here. The question says, where do we use these images? So what do we have here? If you see closely, we have a ambu bag here, face mask, there is an LMA, there is a laryngoscope, there is an ET tube. So where do we use this? We are going to use this in, yes, airway management. So next topic is airway management, mainly the equipments. So airway gadgets can be divided as definitive airways, extraglottic airways, supraglottic airways, and adjuncts. So definitive airway examples are endotracheal tubes. The extraglottic airways are combi tube and king laryngeal tube. The supraglottic airway devices are LMA, that is LMA classic, iGel, etc. Other adjuncts and accessories are face mask, ambu bag, nasopharyngeal airways, oropharyngeal airways, and bougie. So definitive airways are the airways that pass through the vocal cord and are situated below the vocal cord. Examples are ET tube and double lumen tube. Tracheostomy and cricothyroidectomy also are known as the definitive airways. So let me show you a tube. Can you see this? Yes. What is this? Okay, this is an endotracheal tube. Okay, so it is very flexible. Fine. So what are the parts? This is the body, this is the connector, this is the tip, and this is the cup. So what is this? This one, this is the Murphy's eye. Okay, so how do you calculate the size of the ET tube? Size of the ET tube can be calculated by this formula. So in a children aged 1 to 6 years, you have to calculate it by dividing the age by 3 plus adding 3.5, and children above 6, it is by age by 4 plus 4.5. And what is this? If you want to calculate the depth of insertion of tube, you need this formula, age divided by 2 plus 12. Okay. So till where are you going to put the tube? That is the question. So age by 2 plus 12. So as I showed, endotracheal tube has a cuff. They can be classified based on the type of cuff. We can have a high volume, low pressure cuff. The one I showed here is a high volume, low pressure cuff. If you can see, it has got a good surface area that is touching the lumen of the trachea. Whereas we also have the red rubber endotracheal tubes that were used earlier, which had a very high pressure with low volume. So the ideal cuff pressure we should maintain is around 20 to 30 centimeters of water. Fine. Okay. And how to measure the cuff pressure? It is by this gadget called cuff manometer. Fine. So coming on to some special tubes. This is uncuffed tube used in children. It was first designed by Cole. It had a tapering end. So the Cole's tube is a specialized pediatric tube. We also have a similar tube which is long and slender. This is the adult size tube which is long and thin and slender. This is called the microlaryngeal tube. It is used by the ENT surgeons during microlaryngeal surgeries. What else do they use? They use laser resistant tubes. As you can see, they have two cuffs. One of the cuffs is filled with ink or methylene blue dye. Okay. So, sorry, it is filled with dye granules, and we insufflate it with saline or distilled water. Intraoperatively, if there is a injury due to laser, it will leak. Okay. So when it leaks, we'll see the color and we can see that there is a damage. So this laser tube has got two coverings, okay, that make it laser proof. We have some special tubes called the RAE tube. These have preformed curvatures. These were designed for maxillofacial surgery in children, and we have two types of tube, north pole tube and south pole tube. North pole tube, the connector faces the anesthetist or the machine, whereas south pole tube, after insertion, the connector faces the foot end or the south end. Okay, so basically south pole tubes provides a very good surgical access for oromaxillofacial surgeries, whereas north pole tube can also be used for nasal intubations using fiber optic bronchoscopy. So we have something called as armored ET tube or the flexometallic tubes. These are having an embedded metallic wire within their wall. This prevents kinking of the tube when inserted, but they have a memory, so they can leave kinks when too much pressure is put. Next gadget is face mask. This is called Rendell-Beckel-Sosek mask. Okay, this is used in children. We also have adult anatomical masks. They can be colored or they can be transparent. These are to be used in combination with the ambu bag. And before holding the mask, you are supposed to open the airway. Please focus. This is a very important concept for your exam. Okay. Wondergrape says A. Okay, fine. Airway opening techniques. So first one is, what is he doing here? He is putting the head down, head tilt, and is pressing the chin up. Chin lift. Head tilt, chin lift. Okay. The other one, he is trying to stabilize the jaw or the neck here. Okay. And he's giving a thrust. So that is jaw thrust. So where do we use this? For all our patients in OT, we use this head tilt, chin lift. In trauma victims, where we have to rule out the cervical spine injury, we are going to use jaw thrust. So we are going to apply the jaw thrust, we are going to perform the inline stabilization of the neck, and then we are going to put the cervical collar. So remember airway opening maneuvers. Jaw thrust in cervical spine injury, head tilt chin lift in all the patients. Head tilt chin lift has been asked for many occasions in your NEET and INI-CET. So mask holding can be by one hand technique or two hand techniques. This is by C and E technique. I won't go into details. Okay. So you can use one hand or both the hands for holding the mask. If you have assistance, two hands are better. Next gadget is oropharyngeal airway. It's a plastic device. The length is measured by the angle of the mouth to the tip of the earlobe. So how do you insert the oropharyngeal airway or the giudal airway? You open the patient's mouth wide. Remember, oropharyngeal airway can be put only in unconscious patients. Okay, so you make it face upward and push it backward and then rotate, and it fits snugly like this, and it provides a good patent pathway for the air to pass. You can also use the nasopharyngeal airway. So have you seen this in your OT anytime? The nasopharyngeal airway. It's made of soft material, okay, atraumatic. We are going to lubricate this, and we are going to put this in one of the nostrils. We are going to hold it like a pen and direct it into the oropharynx. Provides a good passage for the air. Laryngoscopes were asked in the yesteryears. We have two types, mainly Macintosh that has a curved blade, and we have Miller that has a straight blade. So we have the Macintosh and we have the Miller. And this is something called as a McCoy blade. It is used for difficult intubations. It is derived from Mac blade, as you can see. They both are almost similar, except that the tip here has a hinge and it moves when you press this handle that works by a pulley mechanism. So remember, when you use Mac blade while intubating, you are not going to lift the epiglottis, whereas Miller blade that you use in children, we are going to lift the epiglottis while intubating. Okay. If you can't intubate using a normal laryngoscope, we may need to use a fiber optic bronchoscope or a rigid laryngoscope. So this one, Bullard laryngoscope, has a preformed curvature. We don't use it. We prefer fiber optic bronchoscope. Vinay Prasad says good evening. Good evening. Good evening, Vinay. Thank you. So coming on to the next gadget, that is video laryngoscope. These are nowadays lifesaver for most of the anesthetists. It brings down the chances of it increases the success rate of difficult intubation by 50%. So we have many types. We have King Vision, we have CMAC and all that. Okay, so this one is based on again based on Mac blade. It has a preformed curvature. It has a monitor attached to the handle itself. Okay, these are all disposable blades, very expensive, but we also have some gadgets that can connect to a monitor. Okay, these have a light source at the tip, also a camera at the tip. So this is what we see during intubation. Most of you may not have got a chance to intubate during your internship or practice. So this is what we see when we're doing intubation. So our focus is always on seeing these white structures. These are nothing but the vocal cords. Okay, and we are going to put the tube here, and this view was classified by Cormac Lehane. As you know, every patient is different, every view will be different. So he graded the views, and patients who had full 100% view of the glottis, he classified as Cormack-Lehane grade 1. Those with partial view, grade 2. Those in whom only the epiglottis was visible, grade 3. And in patients where there was no glottic structure visible, he classified them as Cormack-Lehane grade 4. Remember, CL grade 4 is associated with difficult airway in 94 to 95% cases. So it's a alarming thing. Okay, so we'll end the airway management with rapid sequence intubation. So what is it? Rapid sequence intubation is a technique in patients, especially with full stomachs, where we want to intubate and take them up for emergency surgeries. We'll be giving them 100% oxygen, 2 to 3 breaths, and we are going to give IV induction agents and the short acting muscle relaxant, that is suxamethonium. We can put by Sellick's maneuver, that is by providing cricoid pressure of 30 newtons. Remember, 30 newtons backward upward pressure. We can perform direct laryngoscopy and pass the tube under suxamethonium. Okay, so this is called the rapid sequence intubation. I expect a lot of new questions from airway management. Kindly go through this again. And regional anesthesia topic of late is not a favorite of examiners. However, they are asking some regional blocks other than spinal and epidural. So I'm going to cut short the discussion. So as you know, there are 3 important central neuraxial blocks that are there. Okay. So the first one is spinal block, and then where we have the epidural block, and then the caudal block. In spinal block, we are going to inject the local anesthetic solution into subarachnoid space. Whereas in epidural, we are going to inject the drug into epidural space, and in caudal block, it's a type of epidural block we give in the infants. We are going to inject the drug in the epidural space. So this is often asked in your exams. What is the order of blockade in spinal anesthesia or epidural anesthesia? So first to get blocked are the autonomic fibers. So you'll see the sympathetic blockade, followed by the C fibers. So there is loss of cold and temperature, followed by A delta and A beta fibers. So you will lose pinprick and touch. So touch is last to be lost. So what are the indications? As I told in the beginning of the class, these blocks are useful in surgeries that are done at the level below the umbilicus. So what are those surgeries? It could be gynecological surgery, cesarean section, appendix surgery, or it could be hernia repair. It could be umbilical hernia repair. Okay, yeah, umbilical hernia can be repaired under spinal and epidural. Okay, it could be lower limb surgery, foot surgery, etc. Okay, so what is the contraindication? Remember, any coagulation defect is a absolute contraindication. Along with that, patient refusal. Okay, also this question is often asked. If the platelet level is below 75,000, we try avoiding spinal, but if it is below 50, absolutely contraindicated. Okay, fine. Single shot spinal can be tried at 75,000, but below 50, no spinal. Got it? Okay. Patient refusal, remember, is an absolute contraindication for these blocks. So what are the structures pierced? Okay, so you must have seen the anesthetist giving spinals like this in the OT. So first structure to be pierced is skin, then the subcutaneous tissue, then the ligaments, that is supraspinatus, infraspinatus, and the ligamentum flavum. So skin, subcutaneous tissue, and 3 ligaments. Okay, then you'll enter the epidural space. So if you're giving epidural block, you will inject the anesthetic here, or you'll pass the catheter here. This can be confirmed by using loss of resistance technique or hanging drop method. So if you are giving spinal, you go further, you pierce the dura and the arachnoid mater, and you'll enter the subarachnoid space where there is CSF, and you are going to inject the drug there. Okay, yeah. So to give spinal, we have spinal needles. There are dura cutting type of needles and pencil tip needles. Dura cutting needles can cause PDPH, but they are commonly used. The commonly used ones are Vinke. The pencil point ones are Whitaker needles. So the tip will be similar to something like this. It won't be pointed. Okay. Yeah. So they are also color coded. Remember, thicker the needle, smaller the number. And we use 18 gauge or 20 gauge spinal needle for lumbar puncture in the ICU setting. Whereas we keep the thinner gauge needles like 25, 26, 27, even 29 we use for cesarean delivery. So epidural to give, we need the epidural needle as well as the epidural catheter. And there are two types of epidural needles. Those with the curved tip are called Tuffy needles, and those with straight tip are called the Crawford needles. We pass the epidural catheter when we need to give a block for a longer duration of period, or if you intend to use the block for post-operative analgesia. Okay, or you can use single shot epidural in otherwise. So the drugs used for spinal anesthesia most commonly is bupivacaine followed by lignocaine. Okay, epidural we use both bupivacaine and lignocaine. We use lignocaine with adrenaline for test dose of epidural anesthesia. What we do there, after passing the epidural catheter, we give around 3 ml of lignocaine with adrenaline that contains 15 micrograms of adrenaline. We'll see if there is any change in heart rate or BP. If there is, that means there could be intravascular placement of the catheter and we need to remove it. Otherwise, we are good to go. We can use it for all purposes. So what are the complications of these blocks? Most common complication being hypotension. To correct this, we give IV fluids. Also, we use vasopressors, commonly phenylephrine, ephedrine, and mefentrine. Ephedrine and phenylephrine are commonly used in obstetric OT. So, urinary retention can also happen post spinal anesthesia. So, your patient will be absolutely fine, but he has a pain abdomen suddenly. So, that is because of urinary retention. Block has worn off, but still there is retention. Okay, yeah. And if you use dura cutting needles, there is chances of post-dural puncture headache. That means patient will have severe occipital headache, stiffness, or severe headache, which aggravates on sitting up. Okay, and you should advise such patients to drink plenty of fluids, prescribe some good analgesic like paracetamol with caffeine, and encourage IV fluids. Okay, yeah. Coming on to the next part, that is brachial plexus block. As you know, brachial plexus can be blocked at different levels, at the interscalene level, in the supraclavicular area, infraclavicular area, and the axillary area. So the purpose here, interscalene blocks provides good field for clavicle and shoulder and upper humerus surgeries, whereas the mid humerus, elbow, and forearm, we use a supraclavicular block, and the axillary block is very good for elbow surgeries, forearm surgeries, wrist and hand surgeries. Okay, yeah. So coming on to the next part, that is facial blocks. Remember, these facial blocks are often being asked in your recent exams. So there are some nerves in the face that we commonly block in particular situations, like infratrochlear nerve, supratrochlear nerve, supraorbital nerve, and lacrimal nerve, and zygomaticofacial nerve, and the infraorbital nerve. So you should be able to identify the landmark where these nerve injections are given. Okay. Okay, so in this picture, they're showing nerve that is being blocked in this area. So what this could be? Is it greater palatine nerve? No. Is it posterior ethmoidal? No. Is it sphenopalatine? No. It is nasociliary nerve. Okay, fine. The one more question that had come in your exam: blocks for inguinal procedure. Remember, ileohypogastric, ileoinguinal, and genitofemoral nerves can lead to pain sense. These can get affected post inguinal hernia surgery or any surgery in the inguinal region, and they can lead to neuropathic pain. So these nerves can be blocked in turn, so that there is good analgesia post inguinal hernia surgeries. For example, genitofemoral nerve can be blocked using ultrasound, and this provides good analgesia following inguinal hernia surgery. So this is a question that was asked recently. Which of the following nerves is blocked for pain relief in patient with neuropathic groin pain after hernia surgery? So which one? Genitofemoral nerve. Okay, fine. So coming on to the important concept, that is daycare procedure. What is daycare procedure? Daycare procedure is any surgery where patient will get admitted in the morning and go home in the evening. Example, cataract surgery. Okay, some cases it may not require admission also. Example, dental extraction, or some scopy, endoscopy, colonoscopy, etc. Okay, so in such cases, sometimes you are called for giving anesthesia. So what is the preferred technique for such cases? Most of the cases you are called standby, or you will tell the surgeon to do the procedure under local. But if needed, if inevitable, you might have to choose one of these three. The best among these three is TIVA. Okay, so what do we do here? We give IV agents, we avoid inhalational agents, we use LMA instead of ET tube, and we use all the short acting drug combinations like midazolam, propofol, rocuronium with sugammadex. If that is not there, you may use mevacurium if it is there. Okay, and for analgesia, use short acting agents. If you want to use opioid, use a short acting opioid like remifentanil. Okay, fine. So following daycare surgery, patient procedure or surgery, patient has to go home. So he is not able to go home and he may need admission. Why is it so? Because he may be having nausea or vomiting. Severe nausea and vomiting may be triggered by any of these agents, or patient having hypotension or pain. But the most common cause for delay is post-operative nausea and vomiting. Remember. So when do you discharge? Patient can be discharged home after checking for modified ILD criteria. So you check for the activity, respiration, circulation, consciousness, and saturation of the patient. If it is all good, and if your score is above 9, and then he is safe to go home, you can advise discharge with safety instructions, and he should be told to come back if he has any issues. Okay, so what is the most common cause for delay, guys? Most common cause for delay in discharge? Yes, post-operative nausea and vomiting. Coming on to the last part of the session, that is oxygen therapy. This is a very important concept. Guys, after corona, this has been asked in almost every exam. We are going to finish very soon. Try to stay with me. Okay, yeah. So what is oxygen therapy? Oxygen therapy is prescribing oxygen and supplementing oxygen in a patient who is in need. What is the purpose? It is for increasing the FiO2 and increasing the arterial oxygen tension. So it corrects acute arterial hypoxemia. Okay, so when do you know it is corrected? You are going to monitor patient's saturation by pulse oximetry. It's a non-invasive method, and invasively you are going to do ABG to know the PaO2 and SaO2. Okay. So what are the indications for oxygen therapy? So now if you see, most of the hospitals have oxygen. They are all equipped with central oxygen and whatnots. So the indication here, but not every patient gets oxygen, remember. Okay. So we are going to give oxygen in a patient who may be in arrest or may have recovered from cardiorespiratory arrest, who is having hypotension with a systolic BP of less than 100, and who may be hypoxemic. It can be acute hypoxemia or chronic hypoxemia due to respiratory distress like ARDS or pneumonia, or acute asthma or COPD due to shock or any congestive cardiac failure. In these cases, patient will have hypoxemia, so you have to address it. You have to treat the cause as well as supplement oxygen. Patient can have hypoxia in case of severe anemia, respiratory failure, acute MI, and metabolic acidosis or carbon monoxide poisoning. Okay. Yes. So carbon monoxide poisoning, when I say, I'll remember a clinical picture. There was this incident. A patient was brought to hospital after he was trapped in a house in the middle of a forest fire. He was fine. When he came to casualty, his saturation was 99, but he started developing symptoms. Okay. Some neurological symptoms and some things. Okay. But nobody could figure out. Only because of history, we knew that this patient had carbon monoxide poisoning. Remember, it can be deceptive. In case of carbon monoxide poisoning, the SpO2 levels may be normal. You have to do a ABG to know the state of arterial hypoxemia. Okay. So what are the gadgets that we commonly use for oxygen therapy? So remember, oxygen therapy can be given by 3 techniques: hyperbaric oxygen therapy, normobaric oxygen therapy, and mechanical ventilation. In hyperbaric oxygen therapy, we are going to put the patient in a hyperbaric chamber. It is not commonly used anymore. It was very popular during polio epidemic in the 1950s. Okay. So hyperbaric therapy, polio epidemic. Remember one thing. That's it. And normobaric oxygen, that is oxygen given at the normal room atmospheric pressure. Okay, it is given using 2 types of gadgets: low flow devices and high flow devices. Examples: low flow devices, nasal cannula, simple mask, NRBM, tracheostomy mask. Examples for high flow devices: Venturi mask, Ambu bag, then HFNC device, or CPAP or BiPAP device. So if your patient requires more oxygen or more FiO2, which cannot be managed with these 2 type of devices, then you will invariably have to give mechanical ventilation. So you have so many devices. Okay. You have the hyperbaric oxygen, you have the normobaric oxygen in that low flow and high flow, and we have the mechanical ventilation. Whom do you give what? How do you decide that? So to do that, you have to assess the patient. You have to see the need. What does the patient need? And will it benefit him? Is it economically affordable? And most importantly, what is going to be the most comfortable way of treating his hypoxia? Okay. So if the patient has mild this thing, say saturation is just 90, 92. Okay. And if it is responding to nasal cannula, say 4 liters of oxygen, then you wouldn't put him on ventilator, right? So you are going to start with a low flow device and you are going to escalate upward. Okay. So idea here is when to start the oxygen therapy. You are going to start the oxygen therapy when there is evidence of arterial hypoxemia. So what is that? When there is SpO2 less than 93% and low arterial PaO2 less than 60. Okay. Remember those 2 numbers. Fine. So first, as I said, we are going to start with the low flow devices. Low flow devices are sorry for this. Low flow devices are variable performance devices. Okay. So what they do, they are going to deliver certain volume of oxygen, and depending on how patient breathes, the FiO2 will vary. If the patient is breathing rapidly, he may not get as much FiO2 as desired. Okay. If he is breathing normally, then maybe he'll get the desired FiO2. So the FiO2 delivered in low flow device is dependent on patient's respiratory rate and depth of breathing. Okay. So low flow devices are called as the variable performance devices. Okay. Yes. So the first device is nasal cannula. Here the maximum FiO2 achieved is 40%. It is very well tolerated by the patient. As you can see, patient is putting it on his nostrils and lying comfortably. So he can talk, he can eat, he can drink, and he can do all his routine activity. Whereas this is simple face mask or the Hudson mask, which has a transparent plastic mask that covers both mouth and nose, and it is worn using a headband, and it is uncomfortable to wear for long hours. Okay, and you have to keep minimum 5 liters flow. Okay, so both nasal prongs and cannula, face mask can be useful in patients with asthma, patients with pneumonia, patients with trauma, patients with sepsis, and patients who are in the post-operative care unit. Okay, fine. So how does it work? So whenever you give oxygen, the intention is to increase the FiO2. So when you give 1 liter of FiO2 through face mask or through prongs, it is going to increase the FiO2 by 4%. Remember this one fact. Okay, 1 liter equals 4% of FiO2. Fine. So what is the normal FiO2 at room temperature and pressure? It is usually 20 to 21%. Say 20%. Okay. Okay. So when you give 1 liter, you are going to increase it by 4%. So it will be 24%. So when you add 2 liters, you are going to increase the FiO2 to 28%. When you give 3 liters, it will increase to 32%. Sorry. So when you give 4 liters, it will increase to 36%. Okay, fine. So next device is NRBM or non-rebreathing mask. This was very popular during COVID era because it provided almost 95 to 100% FiO2 because of the reservoir bag that is attached here, and there are one-way valves. There is a one-way valve here and one-way valve here. So this allows one-way movement of the oxygen here, and expired air goes out. There is minimal rebreathing. Okay. So this can achieve around 95 to 100% FiO2 in ideal conditions. So we can give a flow rate of maximum 10 liters. Ideal flow rate is 10 to 15 liters per minute. This is popular for transport of patients, also for patients who have been extubated and who need a high FiO2. Okay, fine. Next gadget is tracheostomy mask. This has never been asked. It can come in your exam. This is similar to face mask, but just worn over the tracheostoma. Okay. So next is high flow devices or fixed performance devices. These deliver prefixed concentration of oxygen. So you have given your patient oxygen with face mask or nasal prongs. Initially with nasal prongs, then face mask. It's not working. Patient saturation keeps dipping. You have tried NRBM also, but patient's breathing pattern is not good. So what are you going to do? You need to give him say 20 liters or 15 liters, and you need to achieve 90% FiO2. So what are you going to do? You are going to use some high flow device which is suitable. The examples include Venturi mask and Ambu bag, HFNC or CPAP or BiPAP device. Okay, starting with the Venturi mask. What is Venturi mask? Venturi mask is nothing but a connector that is connected to the normal face mask. So this connector works on Venturi principle. It allows a particular percentage of FiO2 to be delivered, and it works on air entrainment. Okay, air entrainment principle. So air is drawn in, or the high flow oxygen is drawn in through a narrow port, and it mixes with the room air, which is drawn from the environment here. So oxygen from here, room air from here. So each color is designed to deliver a particular FiO2, and it is designed to work with a certain flow rate. So remember, blue connector, you have to give a minimum flow of 4 liters to achieve a FiO2 of 24%. If you keep 6 liters also, FiO2 will be 24 only. Okay, but don't keep below 4. That is the minimum required. So that way, the maximum FiO2 that can be delivered using Venturi is 60%. So if your patient requires 60% FiO2, what are you going to use? Obviously, Venturi. Okay, fine. Next device is Ambu bag. This was asked in one of your exams. We have seen this during airway management. It's a self-inflating resuscitation system used in combination with a face mask. It's a handheld device. Okay, you have to press the thing here, bag, and it has oxygen connector and a reservoir bag that allows you to deliver 100% FiO2 in ideal conditions. So the next device is HFNC device. HFNC device provides fixed high flows continuously. It allows continuous air exchanges. It can deliver up to 15 to 60 liters of oxygen and an FiO2 of 20 to 21 to 100%. It allows regulation of humidity and temperature. Try to remember this gadget. Try to remember this picture. It was asked in one of the exams. Okay. So let's recall. So we are going to start with cannula and face mask. Okay. So maximum FiO2 delivered with cannula is 40%, face mask 60%, Venturi 60%, and remaining everything you can give around 100%. Okay. Yeah. So coming on to the questions, there is a boy who is receiving 3 liters oxygen by prongs. What is the FiO2 delivered? So how do you calculate 3 liters? That is base is 20. Okay. Plus 3 into each liter gives how much? 4. Okay. So 20 plus 12, that is 32% or 0.32, which is nearest to the 0.32 here. Okay. So the answer here should be 0.3. I think you got the calculation. Fine. Okay. So the next question is, what is the maximum oxygen flow rate that can be kept with simple oxygen mask? So remember guys, you can keep up to 10 liters. So minimum 5 liters and up to 10 liters with face mask. Whereas with nasal prongs, remember you have the pediatric ones and the adults ones. Pediatric ones 0.5 to 3 liters and the adult ones, so the nasal prongs, okay, adult ones 1 liter to 6 liters per minute. Okay, fine. What is the maximum oxygen flow rate that can be kept? That is 10 liters. We got it. Fine. In conventional oxygen therapy, which device will deliver the highest FiO2? So you remember what is Hudson mask? That is simple face mask. What is the maximum FiO2 delivered here? Okay, correct. 60%. Nasal cannula 40%. NRBM, I said no, 95 to 100% under ideal conditions. Venturi, yeah, the green connector 60%. Fine. So which gives you the highest FiO2? NRBM. Okay. Fine. So what is this device? I told you to remember, right? Yes, this is a HFNC device. So as you can see, there is a stand kind of thing and there is a small circuit that connects to patient's noses. Okay. Sorry, patient's nostrils. Fine. So I'll give you a clinical picture. I want you to answer this one. If you are still with me online, you can chat in the chat box. Okay. So comment the right answer here. There is a 43-year-old male who was in home isolation after testing positive for COVID. Suddenly he develops breathing difficulty, comes to emergency department. He is alert and responsive, but he is rapidly breathing. So what are all these? These are signs of respiratory distress. His saturation is 84%. Okay. He was in home isolation, has worsened, and he's come to casualty, 84% saturation. And oxygen is being given through a NRBM at a flow rate of 15. And 1 hour afterwards, like 1 hour later, his saturation improves to 88. So he came with 84. You have given 1 hour oxygen, 15 liters with NRBM mask. So anywhere 90 to 100% FiO2 is delivered. After 1 hour also, SpO2 is 88%. So what do you do here? So what is the target? Target is to bring the saturation above 90 or 92. Okay. So thank you, Bharat. So what are you going to do here? You are going to change the device. You are going to upgrade. So I said no, from low flow, you are switching to high flow. What are you going to use here? Okay, so we'll try to see the options. What is the next step? No specific intervention. Wrong. Decrease the flow rate. No, you can't do that. Okay. You can use HFNC. You can use endotracheal intubation. So you have to choose between these two. Okay, but see, I'll tell you, this was a situation which we faced very commonly during COVID. Patients will come to you, their saturation will dip. They'll have happy hypoxia. Patient will be smiling and they'll have a saturation of 80, 82. What would you do? Will you intubate right away? So after treating a lot of cases, we realized that if the patient is alert and responsive, okay, that means he's still okay. So you can try using HFNC. But if the patient has come to you in an unconscious state or where airway is threatened, see, if the patient is alert and responsive and still breathing, that means his airway is patent, he's breathing properly. So you don't have to intubate immediately. You can wait. You can wait for HFNC to work. Okay, so in this case, I would go for HFNC. But if the same scenario, if the patient was unconscious, unresponsive or something, such words, if you see, just go for airway protection, that is secure the airway, put the tube, connect to ventilator. Okay, yeah, fine. So the answer here was HFNC. So that brings us to the last topic for the day. This is not the last, sorry, there's one more small topic. Yeah, so that is mechanical ventilation. We'll just see what is very relevant in this concept because it's a very vast topic. Fine. So when do we choose to ventilate? When do we choose to put the tube? When will we intubate? So as I said, patient is going bad progressively. Patient is developing progressive acidosis with hypoventilation, breathing efforts are coming down, and there is impending respiratory failure, or there is already acute respiratory failure. So there the pH would have dropped, acidosis will be there, PCO2 would have gone up, and you have to put him on ventilator. If there is any evidence of severe hypoxemia with low arterial oxygen saturation or PaO2, you are going to put the patient on ventilator. In a patient who has not completely recovered after a prolonged surgery, after prolonged GA, you should allow the patient to recover. Say if the patient underwent a bypass surgery, or if the patient underwent a prolonged neurosurgery, maybe 12-hour surgery. So in such cases, you got to allow the patient or his breathing to return normally. So you got to support his breathing. So prophylactically, you are going to put him on ventilator. In patients with low cardiac output states like shock, where they can suddenly collapse, better to put them on ventilator. And in case of head injury, you are going to do something called as the purposeful hyperventilation to reduce the intracranial pressure. You need to put them on ventilator. Okay, fine. So ventilators can be two types, invasive and non-invasive. In invasive, you are going to put the tube. In non-invasive, you are just using a mask to ventilate the patient. Okay, if the airway is threatened, always better to go for invasive ventilation. If the patient is in borderline and still able to breathe, but situation worsening, you can try for non-invasive ventilation. Okay, so what are the different modes? So positive pressure modes, negative pressure modes, and all these things I'm not going to go in detail. Just remember, positive pressure ventilation is what we use at present. Just remember that. And what are the basic settings that we are going to set in a patient when we connect him on a ventilator. So the basic settings that needs to be set in a ventilator are the tidal volume. So we are going to adjust the tidal volume at around 7 ml per kg ideal weight. Okay, what is the ideal weight? How do you get it? You get it by height in cm minus 100. Okay, so for his height, what should be the ideal weight? So multiply that by 7. That is what the tidal volume you are going to keep in the beginning. Okay, and respiratory rate. So what should be the ideal respiratory rate? It is different for children, different for adults. Okay, generally 12 to 14. Okay, and flow rates, this you don't worry about, and flow time, this you don't worry about. That machines will set it on their own. You just have to adjust the inspiration and expiration ratio. So inspiration expiration ratio is very important. So you should allow the patient's lungs to heal or to rest. So based on that, the I ratio can be kept from 1:2 to 1:4. Okay. Yes. And you have to set the FiO2 and you have to set the PEEP. What is PEEP? PEEP is pressure that is there, positive and expiratory pressure that is there in the airway at the end of peak of respiration. So this prevents the alveoli from collapsing. It does something called as recruitments. The sleeping alveoli are made to wake up, in simple terms. Okay, fine. So you are also going to set the mode and you are going to decide the pressure support. Fine. So what are the common modes that we use? That we any patient who is not able to breathe, we are going to put him either on volume control or pressure control. Okay, volume control mode may you are going to set the tidal volume and machine is going to set give that particular volume of air or the oxygen to the patient at a preset rate. Okay, in pressure control it is going to deliver the gases or the oxygen at a air or at that particular pressure, preset inspiratory pressure. Fine. In case of continuous mandatory ventilation, you are going to deliver irrespective of patient's breathing. Your machine is going to give so many breaths to the patient in a minute. You are going to set the volume, you are going to set the PEEP and all the settings that you have set, and it will just keep pumping in that volume. So this continued CMV is useful in patients who are totally unconscious, head injury patients, or who cannot breathe, like the total respiratory failure maybe. Okay, but patient who is awake, we try to avoid this, or patient who is recovering from anesthesia, we try to avoid the mandatory ventilation. Only those patients who cannot breathe on their own completely and totally should be put on this mode. Remember this. If somebody is able to breathe, better to put them on SIMV, that is synchronized intermittent mandatory ventilation. In this mode, the machine is going to assess the patient's breath. It is going to sense if the patient is breathing, and the next breath is decided by the previous breath. Okay, so this is a very good mode, very commonly used also. And there is a pressure support mode where we are going to support the pressure. This is useful in weaning. So initially when we start the patient, so you can put him on assist control or SIMV mode. Okay, and tidal volume, like I said, 7, that is range 6 to 8 ml per ideal kg body weight. And then you have to set the breath, okay, anywhere from 10 to 20 depending on patient's need. And FiO2, this is very important. Based on patient's previous FiO2, you can set the same value, or if the patient is in too much of distress, you can start at 100% FiO2. Okay, and then titrate it. And flow rate, that is how much of oxygen is delivered per minute. It should be somewhere between 40 to 60. Remember, machines can deliver, ventilators can deliver up to 60 liters per minute in one go. So IE ratio I've already told. PEEP, okay, should be kept from 5 to 7 or 4 to 6. Okay, fine. So once you have put the ventilator, once you have connected a patient to the ventilator, you cannot leave him there and forget about him. You have to adjust the settings based on patient's condition. So if your patient's saturation or condition improves, you are going to reduce the FiO2 delivered first, and then they are going to slowly reduce the PEEP. Okay, but if the situation worsens, what are you going to do? If the FiO2 is 50, you are going to make it 60, 70, like that. Simultaneously, you are going to increase the PEEP. Okay, fine. I think you got my point. So when the patient is connected to ventilator, you have to focus on feeding, fluid management, analgesia, sedation, prophylaxis, ulcer prophylaxis, glycemic control, and you should allow him to come out of the ventilator by giving spontaneous weaning trials. You have to give care for the bowel, catheter, and also take care about the drugs that are going to the patient. Antibiotics or inotropes can be de-escalated whenever indicated. Prone ventilation is suggested for patients who are on ventilator for long periods. Patient can be put prone for 6 to 12 hours, sometimes even 18 hours. This allows the lung to recover, and this was very useful during the COVID pandemic. So weaning is disconnecting the patient, or weaning is disconnecting the patient from the ventilator, or it is making him less dependent on the ventilator. So if the patient is recovering, you want to disconnect him from the ventilator, you cannot do it suddenly. You have to gradually step down and disconnect him. So for that, you need to assess the patient. You need to do something called as a breathing trial. So once in a while, whenever you choose to do this, especially in the mornings, we use something called the TPs, and we allow him to breathe spontaneously. Okay, and we have to monitor the vitals, ABGs, and other parameters, and with a continuous monitoring, we can put him on slowly. We can put him on the other modes of weaning, like CPAP or SIMV, okay, or pressure control, pressure support, volume support, or automated tubal correction. These are the modes of weaning, and there is always a chance of this weaning trial to fail. So you have to plan for the failure also. So this is how you make a patient come out of the ventilator. Okay. So coming on to the questions, ventilatory support is often required when the saturation drops below 90. This I said in the beginning, because when the saturation falls below 90, you are going to supplement oxygen, you are going to start with low flow, high flow, and everything. If that doesn't work, then eventually you are going to connect the ventilator, as said. So why do we do this? We do this because tissues become vulnerable to hypoxia below 90%. Okay, that is the answer. So in a patient with blunt trauma to the chest, they have started him on a mechanical ventilation, which is correct about the initial setting. So what should be the initial flow? So what should be the inspiratory flow initially? This I have told, right? Should be 40 to 60. Is it right? This option wrong. What should be the PEEP? It says 20. Is it right? And what should be the tidal volume? It says 15. Is it right? And FiO2 of 100. Among these, I feel FiO2 100 could be a good answer. Let us see what is the right answer. So the right answer is FiO2 100. Okay, so this is how you arrive at the answer. You try to rule out the wrong answers and you arrive at the right answer. Okay, fine. In a patient with ARDS weighing 60 kgs who is on a mechanical ventilator with PEEP of 5, tidal volume of 360, IE ratio of 1:2, ABG shows a normal pH, PaO2 of 50, PCO2 of 48 with a FiO2 of 90. What is the next step? Okay, so can anybody answer this? If you are online, you can chat. You can comment in the chat box. Okay. So patient has ARDS. So there is no question of reducing the FiO2. I ratio we are not going to change. Tidal volume, will it help if we change? If we increase? Patient is having ARDS. So there is no exchange happening. So maybe if you increase the PEEP, it might help. Okay. Fine. So initially there is 90. So there's no point of reducing it to 60. So what is the next best step? It is to increase the PEEP. So in an obese patient with ARDS on a ventilator with a PEEP of 5, tidal volume of 390, I ratio of 1:2, ABG shows a pH of 7.32, PaO2 49, PaCO2 52. Okay, FiO2 is 100. Already FiO2 is 100, but his situation is not so good. Okay, because PaO2 is low here. Okay, so what are you going to give? So two parameters you have to adjust. What are those? One is PEEP, other one is FiO2. Okay, so FiO2 is already 100. What are you going to do? You are going to increase the PEEP from 5 to 12. That might work. Okay, yeah, that is the right answer. So which of the following modes is not used for weaning? So continuous mandatory ventilation, pressure support, SIMV, assist control. So we saw the flow chart in the beginning. So controlled mandatory ventilation I have explained in the beginning cannot be used for weaning. Okay. Okay. Intubated patient on TP's trial develops breathlessness. X-ray reveals whiteout lung. Okay. What is the next step in management? So what are you going to do? Patient has got whiteout lung. What is whiteout lung? It is ARDS. So he has breathlessness. Okay. So what are you going to do? Okay, he is on TP's trial. There are chances that he has aspirated and he has developed whiteout lung. Okay, so what are you going to do? Okay, he is in ICU. He will be on antibiotics. Okay, you can't wait for blood culture to come because it takes 3 days. Okay, fine, and you can't aspirate. Okay, so the best answer here could be vigorous suction and physiotherapy. Okay, that is the right answer. Okay, so coming on to the last topic for the evening. Okay, you're walking by the road and you notice somebody lying unconscious by the road. What is the best next step among the following? So, what are you going to do? Okay, you got to check him first. You got to call for help. You have to check the pulse and start CPR if there is no pulse. I feel this is the right answer. If you guys can comment in the chat box. Correct. Dr. Sonali, you are right. The right answer is 2. Coming on to the BLS sequence in adults. So what is BLS? BLS is basic life support in adults. So first step always is to ensure scene safety. What is scene safety? For example, you are trying to resuscitate somebody by the road who has sustained a road traffic accident. So if it's in the middle of the road, it can be dangerous to you also. So in such situation, you are supposed to shift the patient by the side of the road and then start the resuscitation. So first thing is verifying the scene safety and ensuring the scene safety. Then try to check on the patient, check for responsiveness and call for help. If anybody is around, ask them to bring a AED and you can start assessing the patient. Start with breathing and start checking the pulse. All this checking should be done within 10 seconds. And if the pulse is there and the breathing is normal, just wait for the responders to arrive. But if there is abnormal breathing, you try to support patient's breathing by opening the airway by airway opening maneuvers that I explained during the airway management. You can have a head tilt chin lift, or if it's a trauma victim, try the jaw thrust to open the airway. And if there is no pulse and no breathing, or if the patient is just gasping, you can start the CPR. So first step is ensuring the safety. Second step is checking for the response, activating the emergency response system and getting a defibrillator, and then you got to, okay, so pulse check where you're going to do. So if you're a lay person, you don't have to worry about this, just start compressions. But since you are a healthcare professional, you got to try check for the carotid pulse. Where do you check it? You got to check the carotid pulse between the sternocleidomastoid and the trachea. Okay, do you feel your pulse? Okay, if you can feel your pulse, you are still with me. Fine. So check the pulse and feel for the carotid pulse. If there is no pulse, start chest compressions. Okay, yes. So how should be your compressions? Where to give the compressions? Compression should be given at the center of the chest. Okay, so what it does, it compresses the heart between the sternum and the vertebral column, and it pumps the blood to the brain and other vital organs. To do this, you got to apply forceful rhythmic compressions over the lower half of the sternum. Draw an imaginary line between the nipples and place your heel, place the heel of your palm there, and using the other hand start applying the compressions. Give the compressions at a rate of 100 to 120 per minute. Remember, wrist, elbow, shoulder are all in one line. There should not be any movement at these joints. Only at the spine or the hip the movements will happen, and that will give effective compressions. So what is an effective compression? Compression given at a rate of 120 per minute at a depth of around 5 centimeters or 2 inches, or in a layman's term, 1/3 of the height of the chest. Okay, fine. And you got to give the compressions and allow complete recoil of the chest after each compression. Open the airway, this I have explained, and you give 30 compressions followed by 2 breaths. Breaths can be given by mouth to mouth or mouth to barrier or bag mask device, depending on your availability and situation. So how much breath to give? Each breath should be given over 1 second. And tidal volume, how much to give? It should produce visible chest rise. That much you have to give. And if there are 2 people and already you have put the tube, 1 breath to be given over 5 to 6 seconds. So 10 to 12 breaths per minute. Fine. So 30 is to 2. In case of infants, it is 15 is to 2. Remember this. So mask can be held by single hand technique or 2 hand techniques. I've told this. So once your AED arrives, after 2 minutes, you have to switch the responders and connect the AED. AED is automatic external defibrillator. It will assist the patient, and before delivering shock, it will announce that shock is getting delivered. So you have to stay clear. You have to stay clear of the patient. You should not touch or you will get electrocuted. Shock is delivered. How much shock to give? Around 4 joules per kg. Okay, so around 100 to 200 depending on the defibrillator. Okay, it's given, and after shock, reassessment is done and CPR is continued if there is no response. If there is return of conscious circulation, then give the advanced cardiac life support. And remember, every 2 to 3 minutes, you in that period you got to secure the IV line. If possible, you got to put the tube, and every 2 to 3 minutes you have to give the adrenaline. So this is important. Okay, last bit, adrenaline, strength of adrenaline used. So in CPR, you are going to use 1 in 10,000. Okay, and 0.5 ml, 0.5 mg of adrenaline is given. Where do you use 1 in 1 lakh or 1 in 2 lakh? If you know, please comment in the chat box. Okay, I'll tell you this later. Fine. And do you know where we use 1 in 1000? Okay, you are free to comment. So when to give the shock? Shockable rhythms are ventricular tachycardia, that is pulseless ventricular tachycardia, and ventricular fibrillation. In these conditions, you are going to give the shock. By shock, I mean to say defibrillation. There is another term called cardioversion. So if your patient is having pulse and if he is having arrhythmia, to bring his heart back to normal rhythm, we are going to cardiovert. Okay. Remember this difference. If there is pulse, cardioversion. If there is no pulse, defibrillation. Okay. So this we saw, right? Somebody has already answered there. Yes. Okay. Arrange the following steps in a sequence. Okay. During management of an unconscious patient. So what is the first thing to do? First thing. Yeah, tell me fast. Okay. First thing to do is check for response. Okay. Next, check for pulse. Then chest compression, followed by breaths and defibrillation. Okay. Yes. What is an effective CPR? This I've already explained. So depth of 5 centimeters, complete recoil, okay, and 120 compressions. So we're not giving so many breaths. This is wrong. Okay. So the answer should be BCD. Okay. Fine. Okay. Not true about CPR? Not true. Okay. Chest compression? Correct. Depth? Correct. Complete recoil? Correct. Assisted breath? No, not so many. Maybe 10 to 12. Okay. Yeah. Okay. Coming on to the last question for the day, that is use of adrenaline. Fine. So if you can answer this quickly, I have a surprise gift for you all. Okay. Can attempt. Okay. I hope you can try. Fine. So as I said, in cardiac arrest, we are going to use 1 in 10,000. Okay. So B is 1. So these two options have 1. Then remember, local anesthetics we use with lignocaine 2% adrenaline. Okay. 2% lignocaine with adrenaline. We use 1 in 2 lakh. Okay. Also, we have 1% lignocaine with adrenaline. Okay. There we use 1 in 1 lakh. Okay. So this is right. This is this one. Okay. So B1, C3. So this is the answer. Okay. In anaphylaxis, we are going to use 1 in 1000. Okay. So some of you may not be knowing what to do when there is a case of anaphylaxis. So just remember, give 1 in 1000. All your adrenaline ampules come at a strength of 1 in 1000. So you can just give that. Okay, fine. So to close today's session, before we close, to ace in any exam, you need to understand that exam pattern. So this NEET exam that has 200 questions in 180 minutes. 180 minutes is 3 hours. Okay. But you can't directly sit and solve from 1 to 100. This exam has 4 parts, 45 minutes each for 50 questions each. So 4 sessions. After 45 minutes, that block is going to disappear. So you're going to understand the exam pattern, and you know that for every wrong answer, you're going to lose 1/3 of the marks. Okay. So 50, 50, 50, 50. So you are going to plan your time well. You are going to utilize your time in such a way that in 40 minutes, you're going to solve 50 questions. So make it a habit to solve 50 questions in a period of 40 minutes. Remaining 5 minutes, try to see where you found difficulties or flagged ones, and you can forget about that block after next 5 minutes. Okay, yeah. So you understand the pattern, you make a strategy how you are going to approach to the exam, and you make a schedule. Okay, be it exam or be it your study routine, make a schedule and stick to it. Keep giving mock tests. This is one thing that makes you a rank student. Just keep giving mock tests. More the number of exams you give, more you'll get habituated to it, and you will learn the art of solving the MCQs, and you'll ace in your exams. Try to focus on high yield topics. We tried to do that in today's session, and I'm confident and happy that I could cover almost 95% of stuff that is needed to appear for your exams. And not but the least, stay healthy throughout, eat healthy things, have an exercise routine, and manage your stress properly. Get good 6 to 8 hours of sleep before the day of exam. Remember, it always seems impossible until it is achieved. Okay,